session of understanding the disease. Diagnosis and treatment of Parkinson's disease, presented by the Ohio State University Wexner Medical Center. I am Aristide Merola, and I'm the director of the OSU Center for Parkinson's disease and other movement disorders. If you're here, you are either living with Parkinson's disease yourself, or you care about someone who is living with Parkinson's disease. Whatever your reason is for joining us today, we are glad you're here. And we hope that this series of webinars will be informative and helpful to you as you manage and flourish with this disease in your daily life. Our moderators for today's session will be Clarice Goas and Jessica Trulov. Nurse practitioner Clarice Goas graduated summa cum laude with research distinction from the Ohio State University in 2008, with a Bachelor of Science in Psychology, and completed her Master of Science in Nursing in 2012. Her father's diagnosis of Parkinson's disease contributed to her desire to subspecialize in movement disorders. She worked for 4 years at Wake Forest in Winston-Salem, North Carolina, focusing specifically on movement disorders and Parkinson's disease. And then she returned home in Ohio in 2019 and joined our team at the Ohio State University in January 2020. Nurse practitioner Jessica Trulov graduated from Miami University in 2006 with a Bachelor of Science in Chemistry. She graduated from the Ohio State University in 2015 with a Master of Science in Nursing and became certified as Otogerontology primary care nurse practitioner. She has been working at the Ohio State University since 2015, and she works with both the movement and the cognitive disorder divisions. Please welcome Clarice and Jessica. Jessica, I will let you take the word.
All right, thank you, Dr. Merola. Can you hear me?
Yes, we can.
Yeah, okay. All right, thank you, Dr. Merola. Before we get started with our first speaker, we have a few housekeeping notes for you. All attendees will remain muted and your cameras will be turned off for the duration of the webinar. This session will be closed captioned and recorded for viewing at a later time. As you listen to the presentations, please feel free to type questions you have about what you're listening to into the Q&A box. Just a reminder, please do not disclose any private health details or ask questions on your personal diagnosis or treatment. All questions should be general, related to Parkinson's disease and the presentation content. Throughout the morning, we will pause for Q&A sessions with our speakers and our other panel of experts. We will answer as many questions possible during the Q&A sessions and will save others to answer and publish along with today's recordings.
Joining us today are a few of the Parkinson's experts from the Ohio State University Wexner Medical Center. Dr. Merola, Dr. Park, speech and language pathologist Brandy Heron, Dr. Chainese, Dr. Dom, and Dr. Krishna, as well as our nurse practitioners Jennifer Gudowski and Rosina Davis. We'll learn more about each of our presenters as we move through the morning.
Okay, so now we're going to do some poll questions. I'd like to start with a couple of questions for our audience. On your screen, you can interact with our poll questions by selecting an answer and clicking submit. Let's try a practice question. Did you attend our first session of Understanding the Disease on January 16? Select A for yes or select no. Looks like there's just yes or no to select. Okay. And it looks like 100% of the audience. Oh, we only have one answer so far. Sorry about that.
Yeah, I think it was a little bit quick in
in results.
Let's give a little bit more time for the second question.
Okay. Okay. The second question, it looks like the second question resulted too, but we'll go ahead and read that. Okay. The second question is,
let me just ask, yes, if there is a way to, maybe
restart.
restart from the first question, and let's give a little bit more time so we allow everybody to vote. And maybe, Jessica, I suggest maybe reading all of the three questions out loud, and then we give a couple of minutes to vote, so we make sure that everybody has a chance of voting.
And then we'll do all three. Okay. So the first question is, did you attend our first session of Understanding the Disease on January 16th? Yes or no? The second question, we want you to select from one of the two statements, select the one that you believe is correct. Either one, in Parkinson's disease, non-motor symptoms such as loss of sense of smell and sleep disturbances can start years before the motor symptoms like tremor, rigidity, and slowness are observed. Or the first detectable signs of Parkinson's disease are motor symptoms, which include bradykinesia, which is slowness, tremor, rigidity, and/or imbalance. Non-motor symptoms develop later as the disease progresses. And then the third question is select the statement that you believe is correct. Either cognitive impairment and dementia can occur in around 50% of patients with advanced Parkinson's disease, or cognitive impairment and dementia can occur in up to 80% of patients with advanced Parkinson's disease. So we'll give you a few minutes to answer these questions.
I see a comment that says that the submit button is now working. Okay, good. So previously it was not working. So a second of suspense. Let's see the results.
Oh, there we go. Good. Okay, so we have some results here. So for question one, it looks like about 58% of our audience is new here today. So welcome. 42% was present for our first session of this series. For the second question, 71% selected the correct answer, in that some non-motor symptoms can appear years to decades prior to the onset of the motor symptoms. And then the third question, it looks like we had a pretty good split here, 60 to 40, but the answer is that cognitive impairment and dementia can occur in up to 80% of patients with advanced Parkinson's disease. And we're going to discuss all of these topics in our presentations here today.
Perfect. So I would just like to get us started with our first speaker here today.
Please, can you speak up a little bit? We can hear you a little bit soft.
I'd like to introduce our first speaker today, Dr. Ariane Park. She will be presenting our first talk about non-motor symptoms, focusing on anxiety, depression, and sleep disorders in Parkinson's disease. She received her bachelor's degree in cognitive neuroscience from Harvard University, her master's degree in chronic disease epidemiology from Yale, and her medical degree from The Ohio State University. She completed her internship and neurology residency at Northwestern Memorial and completed her fellowship in movement disorders at Duke. Dr. Park is currently our Vice Chair of Academic Affairs in the Department of Neurology and is co-director of the Madden Center for Parkinson's Disease and Related Movement Disorders. Immediately following Dr. Park's presentation, my co-moderator Jessica Truelove will share how to manage cognitive changes in Parkinson's disease with pharmacological and non-pharmacological approaches. Just a little heads up, after Jessica's presentation, I will return to moderate the Q&A session with Dr. Park. Jessica, and other Parkinson experts. And without further ado, please welcome both Dr. Park and Jessica Truelove.
Hello, I'm Dr. Ariane Park, and today I'm going to be talking about Parkinson's disease non-motor symptoms, specifically depression, anxiety, and sleep disorders. Now, everyone is familiar with the motor symptoms of Parkinson's disease: slowness, tremor, stiffness, walking and balance problems. However, there are non-movement symptoms that can be part of Parkinson's disease. These symptoms are sometimes called the invisible symptoms of Parkinson's because you can't see them from the outside. However, these symptoms can occur during the course of the illness or even before the diagnosis, and the severity can really differ from person to person. Here I've listed the premotor, non-motor symptoms that are commonly seen. Decreased or a loss of sense of smell is probably one of the most common and best characterized non-motor features of Parkinson's. It has a prevalence of up to 90%. The exact mechanism of this loss of sense of smell is unknown, but because it's so common, there has been a lot of interest in this sense of smell being a potential biomarker for Parkinson's disease. However, it's really mostly failed to gain traction as a predictive and clinical feature of Parkinson's disease because it's nonspecific. You can see changes in sense of smell, not only in Parkinson's disease, but also multiple system atrophy, Alzheimer's disease, and Lewy body dementia. Constipation is often seen, fatigue, depression, and also REM sleep behavior disorder. REM sleep behavior disorder is dream enactment behavior during sleep. It can include yelling, laughing, or crying, or even complex voluntary movements, falling out of bed, even some more violent type movements with injury. REM sleep behavior disorder is actually a strong predictor of developing Parkinson's disease, and in many cases precedes the Parkinson's diagnosis by 5 to 10 years. These are the common non-motor symptoms that we see in Parkinson's disease. In terms of neuropsychiatric symptoms, I've highlighted depression, apathy, and anxiety because I'll be talking about these. It also includes cognitive impairment.
Okay, so it looks like with the Zoom platform, we have these technical difficulties when the presentation is pre-recorded. So I'm gonna take over. So Dr. Park, unfortunately, is on hospital service today, so cannot be here in person, but I have a copy of her presentation and it will be my pleasure to present it instead. So give me just 1 second and I will go sharing my screen. Okay, can I have a feedback that maybe Clarice, can you have feedback that you can see my slide deck in the proper way?
Yes, I can, and it looks great.
Okay, so what Dr. Park was saying is that actually Parkinson's disease is not only a disorder characterized by motor symptoms. So it's not only just a matter of tremor or rigidity or slowness of movements, but there is really another big, huge aspect of Parkinson's disease, which is the hidden part of the iceberg. And these are called non-motor symptoms. And non-motor symptoms can be very difficult, both to identify since the very beginning. Sometimes patients tend not to report them because they are not sure they are associated with Parkinson. But we know that these non-motor symptoms are indeed a main source of functional disability. So we have to be mindful in recognizing both motor symptoms and non-motor symptoms. So I want to give you an idea about what do we mean with non-motor symptoms. So there are some non-motor symptoms that can actually happen even years and years before the onset of Parkinson's disease. For instance, a decrease in the sense of smell, patients frequently complain of the fact that even years and years before the onset of tremor, they started having a reduction in their sense of smell. I remember very, very well, I have this family of friends of mine, and I was still a kid when his mother, he started saying that she couldn't smell coffee anymore. And then later when I went to med school, I realized that there was actually the very first presentation of her Parkinson's disease, which happened something like 10 years later. And similarly to the sense of smell, also other symptoms may precede the onset of Parkinson. And those are constipation, fatigue, or depression, or what we call the REM sleep behavior disorder, which means that sometimes people with Parkinson may have vivid dreams, vivid nightmares. So they can yell, scream, or kick or punch during the night. And this is something that can happen even way before the onset of the actual symptoms of Parkinson. So all of these symptoms, when we disclose them and discuss them with our patients, always somebody comes up and says, "Oh, yes, but I have this for a very long time." That was actually the very first onset of Parkinson's disease. So together with these symptoms that we call the premotor symptoms, because they precede the motor symptoms, we also have a huge number of other symptoms that comes together with Parkinson. So not necessarily they can come before Parkinson, but they can come together with Parkinson, and they can create a huge disability. And so it's very important that we address them. And it's also very, very important that every patient living with Parkinson knows about their existence and reports them to the treating physician, because for us, knowing that you are experiencing the symptoms is very important, because in the majority of cases, we can address them. And so we have something in the neuropsychiatric area, which means depression or apathy or anxiety. But also in a later stage of disease, we can also have some degree of cognitive impairment, or also something else that is called impulse control disorder, which means that sometimes there is a little bit of impulsivity, like buying too many things or spending too much money in something that usually, is not the typical behavior of the individual. We can have autonomic symptoms, which means that, for instance, intolerance to the cold weather, or also intolerance to the hot weather, drooling, excessive sweating, or orthostatic hypotension, which means low blood pressure when standing. But also symptoms related to the urinary or genital area can be very frequent. And again, this needs to be discussed, because there are so many different treatments that can be applied. The sleep is a major problem as well. So we know that the quality of sleep in Parkinson's disease is far from being optimal. So there might be these episodes called REM behavioral sleep disorder, in which basically patients may have these vivid nightmares, and they tend to punch, kick, or yell at night, or sometimes even something a little bit more benign, like talking in the sleep. But together with that, also the quality of sleep overall is not very good. And sometimes it's because we just need to adjust the medications. Sometimes it's something that is a little bit deeper than that. And finally, we also have the fatigue, as we said before, loss of the sense of smell, and also the perception of colors can change a little bit with Parkinson. So now, just to discuss them a little bit, what we mean with this definition. Depression means feeling sad, without hope, and this can interfere significantly with daily living activities and social interactions. It is very, very common in Parkinson's disease, and is frequently under-recognized or sometimes the individuals, they are too proud to report it. But it's important to know that depression is something that it is not a psychological problem associated with Parkinson. It's just the lack of a neurotransmitter. So in the very same way in which depression, in which Parkinson is the lack of levodopa, it doesn't only cause the lack of levodopa, but can cause also the lack of serotonin, which is another important neurotransmitter that modulates the depression. And so if we don't have enough serotonin, we may feel unhappy. And this is just a chemical imbalance that can be adjusted and can be fixed. Of course, we don't want to fix everything with just a pill. So we are very much aware of the fact that the treatment of depression is a multidisciplinary treatment. It involves antidepressant, social support, exercise, because the physical activity is critical to produce endorphins. And so every time I have my patients telling me, am I doing right doing yoga? Of course you do. Yoga, but every type of physical activity is very, very critical and important in Parkinson's disease, and also counseling. So we are moving towards an integrated model in order to treat this very bad symptom of Parkinson. But when needed, we can also use pharmacological therapies. And there are so many different pharmacological therapies. As a matter of fact, one medication that we use, the pramipexole, that we use for the treatment of motor symptoms of Parkinson, is also actually a very effective antidepressant. But it's not the only medication. So there are so many different medications, and we try to pick up the right one according to each individual subject. Now, sometimes there is a little bit of confusion about what is depression and what is apathy, because something that is very typical of Parkinson is not only having depression, but also having apathy, which means lack of motivation. Again, the lack of motivation sometimes overlaps with depression. So we can have a little bit of overlap between what is depression and what is lack of motivation. And of course, the two of them, they kind of go hand to hand in a kind of a vicious circle. But lack of motivation is really typical of Parkinson and can bring to psychomotor retardation, anhedonia, which means inability to feeling pleasure, lack of energy, lack of enthusiasm. And this is again something that we can treat. And treat doesn't mean necessary taking a pill, but as we said before, it's a multidisciplinary approach. Of course, we also have medications, and we believe that the medication is an important aspect together with all of the other non-pharmacological approaches. Anxiety. Anxiety is definitely very frequent in Parkinson. Sometimes it is a very well justified anxiety. So the fear that the medication is wearing off, the fear associated with the disease itself, or the fear of associated with, finding themselves in a place in which you feel uncomfortable, or maybe because you have to take a medication at a certain time. So there are so many different reasons for anxiety, and this is all very well justified. And frequently, these coexist with depression. But again, this is anxiety, depression, apathy. Those are very well explained examples, very good examples of how pharmacological treatment, counseling, and non-pharmacological treatment, and also physical activity and a number of other non-pharmacological interventions should really be considered all together. We mentioned before the sleep disorders. So sleeping is a very delicate thing, not only for people living with Parkinson, but for everybody. The cycle of sleep can be fragmented in Parkinson's disease, and so many factors can contribute to that. So what I'm saying is that Parkinson itself is associated with a poor quality of sleep. On top of that, if we have anxiety, if we have depression, those are additional factors that can worsen the quality of sleep. So we can have insomnia, which means having trouble falling asleep. but also sleep fragmentation or waking up frequently during the night. And frequently, if we don't sleep enough during the night, we may have an excessive daytime sleepiness. And sometimes this excessive daytime sleepiness can also be triggered by medications. And on top of that, we have what we said before. So this REM behavioral sleep disorder, which means that basically people with Parkinson, they enact their dream. So we all dream, but usually when we dream, it's just in our mind, while people with Parkinson have a tendency to enact their dream, and sometimes this can be violent. And so it's important to report this because we do have therapies for that. And if this impacts your quality of life, we can treat it. So what are the medications for sleep disorders? So again, it's a combination, a very complex combination of medications. It's a very complex combination of cognitive and behavioral interventions, environment modifications. But something that I want to also bring to your attention is that we at the Ohio State, we also have this new study, this new research, which is actually promoted by the Parkinson Study Group. So it's a national effort, and we are a center for that. And this is a study that works with the so-called light therapy. If you're interested in learning more, please feel free to send us an email. And I will present later today an email address. Maybe we can even put it in the chat box, Clarice or Jessica, if you want to go ahead and put it in the chat box. So there is an email address that whoever is interested in participating in research can actually send us an email, and we will be in touch to discuss the clinical trials. And with this, I hand it back to Jessica Truloff. I apologize for the little technical problem, but I hope I represented Dr. Park adequately.
Thank you, Dr. Merola.
You're welcome.
Okay, this morning, I'm going to give a presentation on cognitive changes and dementia in Parkinson's disease. I'm also going to touch briefly on psychosis in PD because it so commonly occurs with PD-related cognitive impairment. I'm going to discuss diagnosis, treatment, and management of these conditions. So this slide illustrates the differences between normal cognition, what we call mild cognitive impairment or MCI, and dementia. Mild cognitive impairment is when you have decline in your cognitive abilities or your thinking and memory abilities, but this decline does not interfere with what we call activities of daily living. Activities of daily living include things like managing finances and medications, cooking, shopping, using the phone, dressing, bathing, etc. Dementia is when the decline in your cognitive abilities is severe enough to interfere with your ability to perform your activities of daily living independently. When you require assistance with your day-to-day tasks, you meet the definition of having dementia. As you can see, there is an overlap between normal and MCI, and there is an overlap between MCI and dementia. This is because there is not a definitive line in the sand for when a person transitions to the next category. It's a gray area, and it's up to the clinician to decide when they feel the diagnosis is appropriate. I want to point out that there are many types of dementia, and the nomenclature can get a little confusing. Dementia is an umbrella term for a condition that affects the thinking and memory to the degree that it interferes with your daily functioning, and that gets worse over time. But there are many types of dementia. The most common type of dementia is Alzheimer's disease. Other types of dementia, though, include Lewy body dementia, vascular dementia, frontotemporal dementia, and Parkinson's disease dementia, or PDD. Today, I'm just going to focus on PDD. Next slide. So what is normal aging? So we can see some changes to the thinking and memory that are considered to be normal with aging. And these changes could be occasionally misplacing things, briefly forgetting an event. But when you're reminded of that event, you should be able to easily recall it. Trouble recalling names of famous people or movie titles, or occasionally hunting for a word. You may get turned around, but only in unfamiliar places. The next column are things that should never change, no matter how old you are. You should always be pretty close with the date. You should always be able to do simple arithmetic with pen and paper. Your planning and organization, insight and judgment, personality and mood, all of these things should not change as you age. Next slide. So what is mild cognitive impairment? We've already touched on this briefly, but here's the formal definition. So the patient is having some cognitive issues or issues with their thinking and memory, but these are enough to be noticed by the patient or their loved ones, and they represent a change from their baseline. There's measurable impairment on cognitive screening, but that these impairments are not severe enough to interfere with daily functioning. And it's important to note that if someone has mild cognitive impairment, this may or may not progress to dementia. Next slide. So what is dementia? Here's the formal definition. It's a syndrome that persists of persistent deficits in at least two of the following cognitive domains. And here are some of the cognitive domains that we look at. Memory, executive functioning and reasoning, visuospatial, language, and personality. These deficits interfere with daily functioning, and the deficits are not explained by other medical or psychiatric causes. Next slide. Parkinson cognitive impairment is common. The prevalence of mild cognitive impairment in PD is about 40%. And then as we saw in the polling questions, we can see with patients with 20 years after the onset of PD, over 80% can have dementia. And when severe, dementia surpasses the motor features of PD as a major cause of disability and mortality. Next slide. So PD cognitive impairment looks very different than other types of dementia. For example, in Alzheimer's dementia, there's a very prominent short-term memory loss and lack of insight. In PD, on the other hand, we see slowed thinking and mental processing, decreased attention and concentration, trouble with multitasking, organization, and planning, decreased initiation of activities. We can see some short-term memory problems, but they're not nearly as prevalent as we see with Alzheimer's disease. Difficulty finding words, and an impaired sense of direction or spatial awareness. Next slide. So Parkinson's disease dementia clinical features, we just covered the cognitive clinical features, but there are also some associated behavioral clinical features that can include apathy, which is a lack of motivation or drive or interest. We can see mood disturbances like anxiety or depression, psychosis, including hallucinations and delusions, excessive sleepiness, sleep issues like fragmentation, which is waking up frequently throughout the night, nightmares or vivid dreams, or REM sleep behavior disorder. Next slide. So when a patient presents with cognitive symptoms in PD, we want to exclude other causes, especially if there's acute decline. There are certainly other things that can mimic cognitive or dementia and that can cause cognitive issues that aren't the PD directly. So as part of the workup for cognitive decline, we want to test for and rule out any underlying medical causes for cognitive impairment that can be treated and reversed. For example, illnesses or infections can cause a more sudden or acute decline. PD-related cognitive impairment and dementia should be a very slow and steady decline that is not noticed on a day-to-day basis. When we see a notable decline over the course of days to weeks, there's typically an underlying medical cause for this, and treating the underlying cause can oftentimes resolve the symptoms. We want to review the medication list for PD and non-PD drugs that can contribute to cognitive impairment. And then we can prescribe medications for cognitive impairment. There are some non-medication things we can do to help with this. And then later, we're going to talk about the work, safety, and social considerations of PDD. Next slide. So here are the medications that we can use to treat cognitive impairment and dementia and PD. We have the acetylcholinesterase inhibitors, and this particular drug class can improve cognitive function modestly in PD. There are 3 drugs within this class. Donepezil or Aricept is the brand name, rivastigmine or Exelon, and galantamine or Razidine. These drugs are FDA approved for Alzheimer's disease. And then the Exelon is also FDA approved for PDD. So we can use any of these 3 drugs to help with cognitive functioning. There's a second drug class that includes memantine, and the brand name is Namenda. The evidence or research for the use of this drug in PD is mixed. So we use this drug on a case-by-case basis in PD. Next slide. So non-medication treatments, I'm just going to cover briefly. So exercise has shown to improve attention and working memory in PD patients without dementia, but the efficacy of exercise in improving cognition in PDD is yet to be proven. But we do know that in cognitive impairment and dementia in general, exercise is very important. A healthy diet is important too, because with a healthy body, you have a healthy brain. A Mediterranean style diet, there's a little bit of evidence to show that this can be helpful for cognitive impairment. And then physical, mental, and social activity are very important for cognitive and brain health. Next slide. Psychosis and Parkinson's disease. This is hallucinations and delusions in Parkinson's disease, and these oftentimes occur with cognitive impairment and dementia. And we can see psychosis in more than 50% of patients on long-term dopaminergic therapy or PD medications. This is a significant contributor to nursing home placement, morbidity, and mortality. The most common type of psychosis in PD is hallucinations, and PD patients with hallucinations oftentimes see animals or people who are not there. They usually know that they're not real, and oftentimes they're not bothered by these hallucinations. But other sensory modalities can occur. We can see auditory hallucinations, which is hearing things that are not there. We can see tactile hallucinations, which is feeling things that are not there. Those are just a couple of examples of other types of hallucinations that occur. And we can see delusions, which is believing things that are not true. For example, thinking there are other people in the house, even though you can't see them. Sometimes the delusions can take on a paranoid nature, like thinking people are stealing from you, or thinking your spouse is cheating on you. But these things are much less common than the visual hallucinations. The risk factors, and there's a typo on this slide that should say risk factors, for psychosis and PD are older age, more advanced Parkinson's disease, cognitive impairment, sleep issues, and then being on medications that can cause or worsen psychosis. Next slide. So for management of psychosis in PD, we want to treat any underlying medical illnesses. So just like underlying medical issues, illnesses, and infections can cause an acute worsening of cognitive decline in PD, they can also cause an acute onset of hallucinations or psychosis in PD. So for example, a urinary tract infection can cause a sudden onset of hallucinations. And then once we treat the infection, the hallucinations will go away in many cases. We want to discontinue medications that may exacerbate the hallucinations. We want to reduce or discontinue PD medications that can be contributing to the hallucinations. Some of the PD medications are more likely to worsen the hallucinations than others. So we need to pay close attention to your particular PD medication regimen if the psychosis is occurring. Non-medication strategies, this applies if the patient does not have insight into the hallucinations or delusions, if they do not, or if they believe that what they're seeing or believing is real. So the caregiver in these cases can try to reorient them by just reminding them that what they're experiencing isn't real. Or if that doesn't work, the caregiver can redirect them by just trying to divert their attention onto something else. And sometimes that can work quite well. And then there's a couple of different types of medications that we can use to treat the psychosis in PD. Next slide. So these are the two types of medications that we can use to treat psychosis in PD. There's the antipsychotic drug class. And these are the three antipsychotics that are the safest to use in PD. Quetiapine, and the brand name is Seroquel, clozapine or Clozaril, and pimavanserin or Nuplazid. Historically, all of the antipsychotics reduce or decrease dopamine in the brain. So there is a risk of worsening the motor symptoms with Parkinson's disease. Quetiapine and clozapine are two of those medications, but of the antipsychotics, they are the least likely to worsen motor symptoms. So they have always been the safest to use in Parkinson's disease. Nuplazid is a newer medication that has become a new tool for us. It acts on serotonin, and it's FDA approved for hallucinations in Parkinson's disease. Because it acts on serotonin, we don't have to worry about it worsening the motor symptoms. So that's been a good tool for us since it's come out. And then the acetylcholinesterase inhibitors, which we covered in previous slides, these are the medications that we use to treat cognitive impairment. They can be helpful for the psychosis as well. Next slide. Prognosis of PDD. So dementia and PD is associated with reduced patient and caregiver quality of life, reduced survival, increased risk of nursing home admission, and these neuropsychiatric symptoms like mood, anxiety and depression, sleep issues in the psychosis. Next slide. Okay, so caregiver counseling. As dementia progresses, patients with PD become more and more dependent on their caregiver. And there are many safety and social considerations for caregivers. At some point, a person with dementia will advance to the point that they no longer have the capacity to make their own medical or financial decisions. And it's important to discuss the patient's wishes while they can still make these decisions. So both healthcare and durable or financial powers of attorney should be assigned, as well as living will, end-of-life wishes, and long-term care planning should be discussed. And then additionally, a person with dementia will advance to the point that they require 24/7 supervision for their safety. Potential safety issues include managing finances, as mistakes here could cause great harm to the family. Managing medications, as mistakes here could cause great harm to the patient. And then driving, because mistakes here could potentially cause great harm to many people. And then when a patient lives alone, we have to consider safety concerns such as cooking, for example, leaving the stove on, or the risk of getting taken advantage of, like scam calls or soliciting. And then, of course, one of the greatest safety concerns in PD that only worsens with dementia is falls. Next slide. Social work considerations. So caregivers and PD patients can benefit from having access to resources and support. Here at OSU, us providers and our social worker oftentimes assist with concerns related to all of these things. So for our patients who are still working, we can help discuss workplace accommodations, or filing for disability, or applying for FMLA. We talked about the advanced healthcare planning, but we can help with that, including DNR. Long-term care planning. With this, that you want to keep in mind the need for the 24/7 supervision in the future and what that looks like for your family. If the patient has a caregiver that can provide that supervision, that's great. But if not, you need to think about what the family will do in that circumstance. Will you hire in help into the home, or will you consider assisted living or nursing home placement? So those conversations are really important to have in advance and have a plan in place. Patient and caregiver support groups. There are a lot of great support groups out in the community where you can talk with people who are going through the same things as you are. Home health services, these include primarily in-home physical therapy, occupational therapy, and speech therapy. And sometimes we can bring in nursing to help with medications. We can help with bringing in medical equipment or home safety equipment. In connection to community resources, sometimes there's resources out in the community to help pay for some of these things depending on your individual situation. There are respite care options in the community, and then we can help facilitate end-of-life discussions and hospice care when the time comes for those discussions. So please never hesitate to bring up these concerns with us to discuss, in addition to symptom management and office visits over the phone or via MyChart. That's what we're here for, to help our patients and their caregivers navigate every aspect of this disease. Next slide. And that's all I have today. Thank you for your time.
Great. Thank you so much, Jessica. And thank you, Dr. Park, and also Dr. Merola for stepping in. At this time, I'd like to invite our expert panel to join me for our first question and answer session. Again, you can see Jessica Trulev and Dr. Merola and myself on screen. Please submit any questions in the Q&A box, and we will start to answer them as we are able to. So I will start just with a general housekeeping question. The slides will be made available for printing. They will, after today, likely in the next week or so, they will be uploaded to our website, and you will be able to see the presentations and themselves and the slides as well. You'll be able to print them off if that's something that you're interested in. Now, getting into some of the great questions that you all have asked. Dr. Merola, how widely disseminated amongst more general practitioners, such as PCPs, are the early precursors of Parkinson's disease, such as, our loss of smell, concentration, fatigue, things of that nature? How known is that to the general community outside of movement disorders?
So thank you for the question. This is a very insightful one, and it is actually a big problem. So in 2013, as part of the Movement Disorder Society, we actually made this kind of study. So in Parkinson centers, so not even in general practitioners, but in Parkinson centers, we put a questionnaire asking, do you have drooling? Do you have constipation? Do you have apathy? Do you feel lightheaded when standing up? All of them non-motor symptoms. And then later, next to that column, we put a column, has anybody asked you these questions before? And surprisingly, 50% of the responders said, yes, I do have the symptoms. And of these, 50% of the responders said that nobody asked me before. So this is something that is really overlooked, not only by general practitioners, which I totally agree, but even by general neurologists. So we really have to make a work to disseminate and spread the word that losing the sense of smell or start having abnormal movements might be one of the first symptoms of Parkinson. So at the beginning, you know, there was an argument saying if you don't have a disease-modifying therapy, why you want to know that? Because in any case, there's nothing you can really offer. But now that the therapies are evolving, we're moving forward. We have genetic testing. We'll see that later. We have new potential therapies. So it's becoming more and more important to make accurate diagnosis since the very beginning.
Fantastic. Jessica, I have a bit of a question for you.
Clarissa, sorry if I interrupt. We hear you a little bit soft. Any chance you can speak a little bit closer to the microphone?
Absolutely. Is that better?
Yes.
Okay. So Jessica, I have a question for you as well. So here in Central Ohio, for our patients, is there more of a central, maybe medical source for identifying Columbus area elder care facilities that may specialize in dealing with Parkinson's, or how would patients obtain those resources?
That's a great question. The best way to obtain those resources is to contact a social worker through your healthcare provider, or the Parkinson's Foundation may have some resources, or the Central Ohio Area on Aging has some good resources. I have heard there is an assisted living here in town that is focusing on Parkinson's disease recently. But I think a social worker is your best bet for having the most up-to-date information on that.
Fantastic. Dr. Merola, does dopamine replacement therapy, such as pramipexole or levodopa, Sinemet, does that also help to address the cognitive symptoms of Parkinson's disease, or with the motor symptoms, or not?
Yeah, again, I'm so happy to hear these questions because they are so high standard questions that really tells me that, you know, we are really having a great educated audience asking great questions. So I try to address this the better I can. I hope to be clear. So when dopamine is depleted in the brain, there are three different systems in the brain that are associated with dopamine. And two of them are critical for Parkinson. One is the motor system. And so if the dopamine level goes down, we start seeing a tremor, we start seeing a slowness, stiffness, and we all know that. But there is also the mesolimbic system. The mesolimbic system is still a system that works with dopamine. So when the dopamine levels go down, the limbic activity, which is an activity that is critical for motivation, for energy, for well-being, for you know, apathy, as we said before, also that happens. So of course, if our level of interest, our level of mental engagement goes down because we have less dopamine, also our cognitive performance goes down. So it is not uncommon to see patients coming for a first visit and saying, I feel kind of foggy, slow in my thinking. And after we start the therapy, this gets better because there is an activation both on the motor system, but also on the mesolimbic system.
Perfect. And that also answered the question very well of, is there a correlation between the severity of motor and non-motor symptoms?
To a certain extent, yes. So we tend to have more severe non-motor symptoms in patients with more severe motor symptoms. The exception is the tremor. So tremor is the motor symptom that usually is not correlated with the severity of the disease. We can have a very severe tremor, but this doesn't mean that we're dealing with a very severe disease. It is just annoying, maybe can be disturbing, but usually is not associated with a bad type of disease.
Jessica, another question for you. At what point do we start to think about hospice when we are thinking of Parkinson's patients with advanced disease? And a follow-up question of, are patients diagnosed with atypical Parkinsonism, are they also considered for hospice? And is that something that Medicare typically helps with?
Yes, so hospice has some very specific criteria that they use to determine when someone is eligible. The criteria for a patient with dementia, I know very well, and it's very specific. A patient needs to no longer be able to walk or be able to communicate well verbally. There has to be a significant weight loss. So these are the types of criteria we look at for admission criteria based on dementia. Of course, the atypical syndromes would qualify for hospice as well. We're just looking for that criteria to be met. And if there are other medical conditions on board, they may be able to meet the criteria sooner. So if we think we're close to meeting that criteria, it never hurts to order or make a referral and get an evaluation to see if we're close to that criteria being met, because having hospice on board is a very helpful resource and tool.
Dr. Merola, can you talk to us a little bit about how some Parkinson's medication meds may actually cause psychosis or worsen them, and maybe how we might go about fixing that?
Yeah, that's another good point. It is true. So anti-Parkinsonian medications can cause more than psychosis, some little hallucinations. Usually those are called misperceptions, and there are very little hallucinations, like seeing, cats or shadows or something in which we are unsure whether it's real or not. This happens specifically with one type of medications that is called the dopamine agonist. So medications such as pramipexole, ropinirole, levodopa can cause that to a little extent. Selegiline can cause that to a little extent. Inamantadine can cause that to a little extent. However, that's where it's important to have a good Parkinson doctor, because sometimes, general practitioners or even hospital service, they believe that the solution is taking away the medication, but we have to balance all of this. So we have to find the right dosage of medications that can cause good benefit without causing the side effects. We cannot just be black or white, because it simply doesn't work.
Great. Dr. Merola, there's a couple of questions that are all running along the same lines for you to help me answer. So does the long-term use of carbidopa, levodopa, or other medications that we use to treat Parkinson's disease actually cause or contribute significantly to Parkinson's disease dementia?
No, that's an excellent question. Carbidopa, levodopa doesn't really cause side effects related to the exposure. So this is a common idea that is very difficult to eradicate, because what happens is this. At the very beginning of the disease, our brain still has a certain buffer capacity. So when we take the medication doesn't really go act immediately, but is kind of stored and then gradually released. And this is because there is still something like 30, 40, 50% of neurons who are able to create this buffer capacity. With disease progression, the number of these neurons progressively decreases. And so at this point, what happens is that taking carbidopa-levodopa doesn't produce the same benefit that used to produce at the beginning. And so it is a natural reaction to blame the medication and say, you see, I develop tolerance or I develop side effects, because other medications can cause a tolerance and side effects or addictions. But what happens in Parkinson is not directly related to the carbidopa-levodopa. It's more related to the progression of the disease. And so there is a lower ability of the brain to store and release the carbidopa-levodopa in the proper way. And I saw also a question later that goes in the same line. So I save time addressing that. There is a way to measure how much dopamine is still, dopamine activity is still in the brain. So this way is called SPECT or PET. Those are expensive scans that can be done. We generally do them for research. There is no real utility in doing this on just a clinical practice basis because, you know, it's a scan, there are some radiation, and the kind of information we get is not that useful, doesn't really change our approach to the disease. But there is a way to measure how much dopamine is still residual in the brain.
Dr. Merola, I have one, maybe two questions left. One is one that we get all the time in clinic, so I think it's important that we answer it.
Please, apologies if I keep on interrupting, but we really hear you very soft. And if I have trouble, I imagine that also other people have. Try to speak a little bit closer.
Absolutely. There's one question that we always get in clinic that has popped up again, so let's answer it. And I was thinking we might be able to answer one more. But there's always a question of, should one start levodopa and medications for Parkinson's right away? Is there, good benefit to that? Or is it better to delay medications and wait until they're absolutely necessary?
I know that, of course, there are people who are extremists, who say you need to start right away, and some people who say, I don't want to take it at all. And I understand both positions. So after many years in the field, I can say that I really do understand both positions. What I think is that the answer is different for every single patient. In the very moment in which the symptoms of your Parkinson's disease is impacting your quality of life, and you are losing functional capacity because of these symptoms, there is really no reason whatsoever not to take the medication, because the medication can give you back functional ability. And we don't want you to lose your functional ability just because you are stubborn and you want to fight the medication without any help. However, if the symptoms are mild and do not really bother you, there is also no reason for treating them. So the point is, I'm totally supportive of people who say, I want to start the medication as late as possible. I say, I'm fine, I'm on board with that. But as long as this doesn't impact your quality of life. So if I see that you have a significant impact on quality of life, at that point, I do want to start the medication. There is a patient of mine, a very dear patient of mine that maybe is even on the call, who came to me on a wheelchair because she didn't take any medication. And I told her, you cannot do this. And we started together the medication. It wasn't easy, it took months, but we started together the medication, and 6 months later, she was walking at the mall. And she sent me a picture, and that really made my day. So I don't want to see people on a wheelchair just because they don't want to take the medication.
Absolutely. Thank you both so much for your assistance in answering these questions, and thank everyone for submitting their questions. They were really quite fabulous questions that really show that you have a lot of insight into this disease, and just excellent questions. Right now, don't worry if we didn't get to any of your questions. Anything that you've submitted in the question and answer box, We have it, and we will answer them at a later time, and we will post all of the answers to all of the questions on the website. So we will absolutely do that, again, along with the recordings of today's presentation and the PowerPoint slides for you as well. It is now time for our first break, so everyone go run, get a cup of coffee, a drink of water, or use it as a bathroom break, and we will see you back here promptly at 10. So you've got about 10 minutes until we will resume our presentations again. See you soon.
Thank you.
Welcome back. Let's start this session with a poll question. Which of these two statements do you believe is correct? Either in Parkinson's disease, constipation is largely due to the slower transit of stool through the colon, or excessive fluid intake due to dry mouth leads to constipation in Parkinson's disease. We'll give you a few seconds here to submit your answer. Okay, let's see what the answers are. All right, great job. That is correct, 92%. Constipation is due to the slower transit of stool through the colon, and Clarice is going to talk about that a little bit more in her presentation. Okay, let's try one more. Which of these two statements do you believe is correct? Either, oh, it looks like that's the first one. We want to move on to the one about the voice. Looks like they're working on getting that one up. Oh,
We can save it for later.
that's okay, not a problem. We'll save that one for later. We'll move on to our next presentation. Our next speaker is nurse practitioner and my co-moderator, Clarice Goes. Clarice will pick up where we left off before the break by continuing our focus on non-motor symptoms in PD and talking about constipation and urinary dysfunction and how to treat them. Immediately following Clarice will be a speech and language pathologist, Brandy Heron, to present the last of our non-motor symptoms segment on speech and communications, tips and treatment. While you are already familiar with Clarice, let me tell you a little about Brandy. Brandy Heron is an alumni of the Ohio State University, receiving her bachelor's degree in speech and hearing science in 2007 and her master's degree in speech language pathology in 2009. She has been working in OSU's outpatient neuro rehab since 2011 at the Powell, Hilliard, and currently Gahanna clinics. She is a certified clinician in Lee Silverman voice therapy and a provider for the Parkinson's Voice Project Speak Out. Please welcome Clarice Goes and Brandy Heron.
Good morning, everyone. So I will be talking a little bit about bladder problems and bowel problems in Parkinson's disease. So these are things that we don't always talk about, but they can be very frustrating. So we'll give them a good 20 minutes of discussion today and see if we can't help reduce some of your symptoms that you're having. Next slide, please. Perfect. So bladder problems in Parkinson's patients are somewhat common, but they are a little different than bowel problems in that they tend to start later in Parkinson's disease, not earlier on or before motor symptoms. About 30 to 40% of patients have some kind of urinary trouble, and about 15% of folks have really bothersome incontinence. So those are the numbers that we're looking at. Next slide, please. So why do Parkinson's patients have trouble with their bladders? This is an excellent question, and as usual with Parkinson's, it has a couple of different answers. So the biggest problem that my patients tend to struggle with is that their brain is sending inappropriate signals to their bladder that it's full and they need to empty it. Unfortunately, it sends this signal way too often, and it becomes a nuisance. Sometimes it can be during the day, sometimes it can be during the evening, and unfortunately, sometimes it's both. And sleep is really important in Parkinson's disease. It's very restorative to the brain and its ability to function. So staying up all night with a cranky bladder is not a good thing. So we'll talk about how to fix that. Another problem that's less common is difficulty emptying the bladder. And that's just a malfunction of some of your sphincter muscles within the bladder. And so it can cause you some difficulty with actually creating your urine stream and your bladder not emptying fully, which can be frustrating. And then very, very rarely we can see something, dystonia, which is that word we use for muscle spasms. We can see that also in one of your sphincters as well, which can make it difficult. So let's talk a little bit about how to treat some of these things. Next slide, please. So the overactive bladder, having to urinate frequently. There are medications that can treat this, but a lot of these medications we try to avoid. Their side effects are things that we don't want you to have trouble with. So we really try to avoid medications like oxybutynin, and you see some of its other similar medications. Urologists who don't deal with Parkinson's patients often may prescribe these medications. They're not necessarily wrong, but sometimes they can make your Parkinson's slightly worse. So it's a bit of a weighing of pros and cons at times. But a new medication came out a few years ago that does not have that particular problem, called Mybetriq. It has been helpful for patients. I always warn everyone, it is not a miracle cure, but it works really well. So if you're getting up at night, say you're getting up, it feels like 5 or 6 times a night, I would hope when you took this medication that you would be getting up maybe 2 or 3 times a night, or even less. But I think we cut down on the number of times, but it's hard to make it go away completely. And the newer drug, the Mybetriq, doesn't come with some of those side effects that we worry about so much with the confusion or hallucinations, constipation, dry mouth, and things of that nature. So we like that drug quite a bit. Other treatments, we will often send folks over to urologists. It is a great idea to have a urologist that deals with neurology patients, in particular Parkinson's patients. We have been lucky at OSU to have a provider or two such as these, and they know these things, which medications to avoid and which medications can be very helpful. So a good urologist is definitely a great addition to your Parkinson's disease team. Next slide, please. So the other problem that I talked about, not quite as common, but the difficulty emptying the bladder. There's one medication, it's not one that we use a lot, because as you see, it has a list of side effects: low blood pressure, nausea, stomach discomfort, diarrhea, being more tired, flushing, sweating, headache. Nobody's favorite drug. Typically what we will do is we will send folks over to urology and they will talk to you a little bit about maybe intermittent self-catheterization or any other techniques that they may have available, but usually that's the most common. Next slide, please. So the dystonia that happens, for the rare amount of folks that it does happen, we treat those with our typical medications that we use for dystonia, which are all of the medications that you typically take, like your carbidopa, levodopa. But again, that's a really small number of people, so not usually a problem. So let's switch gears a little bit and let's talk a little bit about bowel problems in patients with Parkinson's disease. So usually the number one problem is constipation, but there's also some cramping and bloating, and they're often early symptoms of Parkinson. disease, as you heard earlier with Dr. Park and Dr. Merola's lecture. So this can precede your diagnosis of Parkinson's by several years. And so by the time you're actually diagnosed with Parkinson's, you're usually quite tired of it, which is a normal way to feel. And so we really need to work on treating it. Besides just your frustration with it and discomfort, it's also really important. In fact, I would say that it's vital that we appropriately treat your constipation so that your medications are able to absorb as best as they can. Because we obviously want you to get the strongest amount of medication that you can get from taking your medications. So next slide, please. So why do Parkinson's patients have trouble with their bowels? The biggest trouble is a big word that we use called gastroparesis, which simply means that your gut has really slowed down significantly and it's unable to pick up speed. Unfortunately, your arms and legs are not the only thing that slow down in Parkinson's. Your gut does as well. So if your gut's not emptying as quickly, that means you're feeling full more often. You kind of feel bloated. If you're a person who used to eat bigger meals, you notice you're not interested in that anymore. You would really like to have smaller meals and maybe more frequently, but you're a little bit of a snacker as opposed to a big meal eater. So we'll talk a little bit about how to fix that. And then, as you can imagine, if your gut is slow, it's harder for your medications to absorb as well because everything is slowed down, including how quickly they get through your system. So how do we fix it? There's some thoughts that maybe domperidone can help, but that's a drug that's unavailable in the United States. So we don't often use that as a choice. Duopa, which we'll talk a little bit about at the end of the discussion today. Which is the intestinal gel that goes into your body with a tube, and then you don't take oral medication anymore. So you're kind of bypassing the need to absorb the medication that way. And then future options, there's some talk of patches, subcutaneous pumps, sublingual medications. Essentially, how we try to fix gastroparesis is trying to avoid using the mouth to stomach route. So we try to find other ways for you to absorb your medication so that it won't be absorbed so slowly. Next slide. So also along the same line is the constipation. So this, we describe it very differently. We use it in everyday lingo, but it's just difficulty having bowel movements or decreased number of bowel movements, and likely with Parkinson's disease, a little bit of both. So we're talking that you're using the bathroom less than 3 times a week, but you also may have some cramping, some bloating, some straining, feeling like you can't empty fully, not being able to go at all, hard stools, or the worst case scenario is being impacted, meaning that you're just unable to go and everything gets backed up in the GI tract, which can be really miserable. So we want to talk about certainly how to avoid that. Next slide, please. So how do we treat it? So the good news is the best treatments are not necessarily medications. They are things that you can do every day. So increasing the fiber in your diet. This doesn't mean that you need to run out and take a fiber supplement. That actually may make you feel like you have a big lump full of things in your belly. But increasing your fiber in your diet, more salads, more prunes, more fruits, more vegetables, all the things that are good for us anyways, are very important. If you can add a yogurt to your diet every day, that seems to be something. Probiotics are a very hot topic in Parkinson's disease right now. We're not sure which probiotic. That's always a question that I get, but there are some studies going on looking at probiotics in Parkinson's disease. So, it's not a bad idea to take one of those a day or simply eat a yogurt as well. The other thing is your gut is a tube. And because it is a tube, it needs fluid for things to move. So as I told you, Parkinson's patients tend to have to urinate more frequently. So they do not want to drink enough water. But you do have to drink enough water in order for your gut to move well. So I want you all to stay nice and hydrated. And then exercise is a really great way to get the bowel moving. It's always been that way. So the more you move your body, the more your bowel will move for you. And then lastly, one of the over-the-counter drugs that we use quite a bit and is highly recommended is Miralax. This is a safe drug. We give it to children, so we find it very safe. You can take it every day. It's not going to harm you. And you can also, a lot of my patients will take it every day when they're feeling very constipated, and then they will back off and take it every other day or a couple days a week. It's really important that you don't fall off your bowel regimen just because you're not having trouble. You want to keep things flowing, again, to keep those medications working as best as they can and to keep you feeling as best as you can as well. There are a couple of prescription options for constipation. We don't use them very often. They are listed there, as you can see, with the Amitiza, which puts more water in your stool, but it can have side effects. And so can the Linzess. It is supposed to increase your bowel movement frequency, but side effect, increasing it too much, diarrhea. So again, we don't use those medications as much. We really try to focus on the other options, but they are out there. Next slide, please. So there's a lot of questions about what will the future of the bladder and gut management look like for Parkinson's disease. There's still a lot of discussion of that gut-brain relationship. I'm sure those who keep up on the literature see some of that, quite a bit of that. So that's still in trials. There's still questions about that, and we'll see more of that come out as time goes on. And then again, as I mentioned, there's a lot of studies about probiotics and also the fecal microbiota transplantation that they use often or are starting to use more frequently in cancer patients. There are some questions of whether that is something that might be in the future for Parkinson's patients. We don't know yet, but we will keep you posted as that goes. Next slide, please. I believe that's my last slide. Great. So I am going to go ahead and transition over to Brandy. She is going to go a little higher up on the GI track and talk to you a little bit about speech. And potentially some swallowing things that happen. She is one of our excellent, as she was already introduced, speech therapists here at OSU that is specially trained in Parkinson's disease. So with that, I will give it to you.
Thank you, Clarice. Again, I'm Brandy. I'm a speech therapist at our Gahanna outpatient rehab location. We're going to talk about speech and communication and some tips and treatment strategies. Next slide, please. So what we'll cover today, we're going to talk briefly about drooling and treatments, speech and voice changes that we see with Parkinson's, cognitive communication changes, benefits of speech therapy and those communication tips, and some of our free OSU Parkinson's community classes. Next slide, please. Okay, so drooling and Parkinson's. This is a common complaint for patients with Parkinson's. Unfortunately, the cause isn't completely clear. We suspect that this is due to swallowing less often and less completely. And so because of that, saliva is left to pool in the mouth and then eventually fall out of the mouth. So treating this can also be challenging. Sometimes changes to your PD medications can be beneficial. Additionally, sometimes localized botox injections to the salivary glands can help and provide some relief. And trying to make a more conscious effort to swallow more frequently and to swallow hard. However, this can be difficult because we know with Parkinson's, there can be swallowing issues. It can be difficult to initiate that swallow. Something that some of my patients have found to be helpful is sucking on a piece of hard candy, because when you do that, you're stimulating your swallowing, so you'll swallow more often and hopefully swallow down that saliva. Ultimately, we need more research on the exact cause of this and to help develop some standardized criteria and treatments for this. But if you are experiencing issues with drooling, speak to your Parkinson's providers to figure out what treatment options may be available for you. Next slide, please. Okay, so we have a polling question embedded in here. We'll see if it will work out or not. But I wanted to ask the audience, how many people here with Parkinson's have had a family member or friend tell them that they are too quiet or that they can't hear you? So we can answer both questions. The second question is, have you ever received speech therapy? Whether people have told you you have difficulty or not, have you received speech therapy? So let's give it a couple seconds for those numbers to come in. Okay. All right. So we kind of see a bit of a mismatch here. So it looks like about 77% of people who have Parkinson's on the call have had a family member tell them that they're too quiet or that they can't hear them. And only 36% of people have ever received speech therapy. So what we really want to focus on today is how speech therapy can help you. All right, we can go on to the next slide. Thank you. All right, so the speech and voice changes that we see with Parkinson's, it's called hypokinetic dysarthria. So that's kind of a big fancy word, so we're going to break it down. Hypokinetic means decreased amplitude. So the movements aren't as big as you think they are. So that can be with your face, your mouth, your speech muscles. And dysarthria means difficulty with speech. So putting those together, it means those small movements result in difficulty with speech. So in speech production, we'll see reduced clarity due to imprecise articulation. So this is when people might tell you it sounds like you're slurring or you're mumbling or your speech just isn't very clear. We also see rate changes. So somebody might tell you you're talking too fast. And we also see changes in prosody or vocal melody. So prosody is that normal kind of up and down in pitch that we hear in speech. So sometimes patients with Parkinson's are very monotone. They're only using one tone, and that is a lack of expression in their voice. Also with voice, we may see decreased loudness and a breathy or hoarse vocal quality. Next slide, please. So jumping gears just a little bit, we're going to talk what are some of those cognitive communications changes that we'll see. We've talked a lot about these this morning, but we may see changes with attention. So either sustaining or shifting attention. We may see speed of mental processing slowing down. So you may need more time to respond to questions. We see changes with problem solving or planning, memory deficits, difficulty with word finding. So what we mean by this is when you know what you want to say, but you can't think of the exact word. So this happens to everybody time to time, but it's, you know, when you know this is a pen, but at the moment you just can't come up with that word pen. And also we can see difficulty with language comprehension. Next slide, please. So why do these speech and voice and cognitive changes happen? Again, it's really due to that reduced dopamine. So that causes those motor changes, which affect the muscles of the face, mouth, vocal folds, and respiratory system. And those changes result in decreased coordination and control of the movements needed for speech. And then that brings about that imprecise articulation, that increased rate and hoarse, breathy vocal quality and decreased volume. Over time, these smaller movements can lead to weakness in those muscles. Another challenge with our speech system is that for our patients with PD, there are changes in sensory processing and perception. So it makes it hard for people to recognize when their speech is not clear or it's too soft. So it may feel to you like you're talking loud, but your family member is saying they can't hear you. It's very common that I see patients come in and they say, well, I don't have any trouble speaking, but my spouse, my husband or my wife, they just can't hear. So that's why they don't hear me. They have a hearing problem. So it's hard to recognize those difficulties in ourselves. And with the cognitive changes, again, changes to dopamine and other neurotransmitters can affect cognition. Depression, anxiety, sleep disturbances, and fatigue can also affect cognition. And as we know from this morning, those also occur with Parkinson's. Next slide, please. So all of these changes impact the ability to be heard, understood, and fully express your wants and needs with family members and friends. And this can lead to talking less, being less social. It may impact work if you're somebody who's still working. It can lead to isolation, depression, decreased quality of life, and increased caregiver distress. Next slide, please. So we already answered this polling question, and I believe we said only 36% of people have received speech therapy. So we're going to talk about why is speech therapy important. Next slide, please. There are limited effects with medications or surgery on voice and communication skills. So a lot of the PD medications focus on movements, and then we have DBS also, but those things don't have big impacts on voice and communication. There's limited and consistent effects of just focusing on the way you say words. However, there's a lot of evidence-based research that demonstrates success with intensive treatment, focusing on ramping up vocal effort and volume. Next slide, please. So there are two main voice therapy programs that are offered by myself and other speech therapists here at Ohio State. The first one is called LSVT Loud, which stands for Lee Silverman Voice Therapy. This was developed by Dr. Lorraine Ramig, and she was working with a patient named Mrs. Lee Silverman, and Mrs. Silverman's husband said, if only we could hear and understand her. So that was really the driving force to help develop a therapy to make it so we can hear and understand our loved ones more. This therapy has years of evidence and support from the NIH. It's one of the most researched therapies in speech therapy. It has a strict protocol of 4 times a week for 4 weeks, 1-hour session. So it's a total of 16 hours of therapy in person with a speech therapist. A newer program is called Speak Out, and this was developed by the Parkinson's Voice Project, and specifically by a therapist who felt restricted by insurance benefits for her patients. So she developed a nonprofit organization, the Parkinson's Voice Project, that works off of donations. And this program continues to provide affordable training for therapists like myself so that we can continue to help patients with Parkinson's with their voice. This program, the treatment protocol is less rigid. We can see you once a week, 2 times a week, 3 times a week, whatever works for you, up to 25 sessions total if needed. So both of these programs focus on increased intensity, loudness, and intent through a series of structured tasks. And even though they're structured programs, they can really be tailored to fit your individual needs, deficits, and interests. Next slide, please. So here is a sample of what we would do in a voice therapy session. We always start off with breathing exercises because your breath support is the powerhouse to your speech. We need that breath to go from your lungs, up your vocal tract, out your mouth to provide speech and volume. So we always do that and some vocal warm-ups. We do a lot of repetitive, sometimes long and loud ahs. So that would sound something like this. So we do that a lot, and that is really to retrain your brain what loud sounds like and feels like. We also do pitch glides so that you can better control the pitch and you can have a more dynamic voice. We work on functional phrases. So we can develop phrases that you may say in your everyday life. So if you're still working, they can be built around work. If you have activities that you like to complete in the community, they can be built around those activities. Just talking at home with a spouse, we can develop phrases for that. And then finally, we always work on some cognitive linguistic tasks because when you're talking, it takes some of your mental energy to think about what you're going to say. And now we're also asking you to think about how you're going to say it. So it can be difficult to pair those two things together. So we practice that in therapy. And again, all of these tasks can be very individualized and patient specific. All right, next slide, please. So both of these therapies have really great results. For LSVT Loud, we have seen that those result in improvements in loudness and more variation in pitch while speaking, last and maintain for at least 2 years post-treatment. And improvements have also been seen in articulation, facial expression while talking, and speech-related brain changes. And Speak Out research has shown that participants achieved statistically and clinically significant improvements in speech intensity and pitch range after Speak Out. And this was seen on patient-reported outcome tools and perceptual speech evaluation scores. Next slide, please. Okay, so talking a little more about cognitive communication treatment and what we would do in therapy. So with this, we are really trying to provide strategies and tools for you to use to help with your deficit. So we would develop personalized word finding strategies. So what are situations where you're having trouble communicating? And we would practice some strategies to help you come up with your words easier or figure out what to do if you can't come up with the word you want to use. A lot of times this can be paired with the voice exercises, so we can work on 2 things at once. We also develop memory strategies or planning, organization strategies to help you function better at home or in the community, or if you are working. And again, it's very individualized. Next slide, please. Oh, I also wanted to mention real quickly about in our treatment sessions, we will educate family members as well, because a lot of times we need those family members to help to promote using these strategies at home. Or if your loved one is having trouble, what are things that you can say or do to help get them to communicate what they need to? So we provide a lot of family education as well. So how can you get started with speech therapy? You can ask your physician or provider for a referral. And what you would do is you would come in for an initial assessment, and we would determine your specific needs, goals, and develop a personalized treatment plan. We aren't going to talk actually about swallowing today, but just so you know, speech therapists do also work on swallowing disorders. So if that's something you're having difficulty with, you can also talk to your provider about a referral for speech for swallowing. And after that initial treatment session, we would schedule follow-up sessions. We like to see people weekly if able, but we try to be flexible with what works for you. So we'll have patients who live an hour or 2 away. So we may only see them once every other week or once a month. And in all of our OSU locations, we also have occupational and physical therapy in the same building. So some people come and see all 3 of us in one day if they have needs for that and can handle that. And we do have locations throughout Columbus. So we have locations in Gahanna, which soon will be moving to a new building in New Albany. We have a location in Hilliard, location in Powell, and a location at Martha Morehouse, which is near OSU's main campus. Next slide, please. All right, so some general communication strategies. So for people with Parkinson's, something you can do is try to increase your volume when you're talking. Like I said, it can be challenging and you might feel like you're yelling. That's a big thing I hear when I tell people to be louder. They say, oh my gosh, I can't talk like this, I'm yelling. But you can get feedback from your either speech therapist or family and friends. They'll probably tell you that you just sound like you're using a normal volume when it feels like to you, you're yelling. So try to increase that volume. Make sure you have the listener's attention before you start to talk. So a lot of times we just get going and talking right away, and maybe the person we're talking to is doing something else. They might miss the first half of what we've said. So sometimes creating an attention-getting phrase can be helpful. So before you start talking, say, hey dear, hey Mike, I have a question, and pause and wait for that person to look at you, and then you can start talking. Patients always tell me, my spouse can't hear me when I'm in the kitchen and they're in the living room when I start to talk to them. But that's really not set up for great communication. We really want to be face-to-face with people when we're talking. We get a lot of information from watching the person's mouth and face move. So try to be face to face as much as possible because you're going to be able to hear and understand each other better. And eliminate distractions and background noise when you're talking. So turn off the radio or the television to really focus on each other. And for family members and friends. So as we said, there can be some delayed processing with Parkinson's. So make sure you're giving your loved one time to process what you're saying and respond. Don't pretend that you heard or understood them. If you didn't, you can ask them to repeat themselves. And use the teach back method. So if you think they said something, repeat it back to them to confirm that you understood correctly. Next slide, please. All right, lastly, we're going to talk about some of our OSU PD community classes. We have a great series of classes within OSU. Right now, all of these classes are free. We have funding through the Parkinson's Foundation. There are moving and walking classes, but we're going to focus on the Speaking with Purpose class. So this is a free voice class that is instructed by a board certified music therapist in collaboration with a speech therapist. It includes rhythmic movement exercises, diaphragmatic breathing, voice exercises, singing, and just speaking to one another. Research has shown us that targeted training for voice and therapeutic singing have been associated with lasting changes for people with Parkinson's in regards to vocal volume, speech intelligibility, and overall mood. So this is just an amazing class. I've had patients tell me they're hesitant to join because they don't want to sing. There's only a very minimal part of singing in this class. And during those parts, actually everybody is muted and you can only hear the instructor. So I really encourage you to join. It's offered on Zoom. It's on Thursdays. You would choose one of two times, 10 to 11 or 2 to 3. This has a rolling admission. So I believe the class just started 3 weeks ago or so, but you can join at any time. So to get more information about this, you can check out our website, wexnermedical.osu.edu/PD All right, next slide, please. So in summary, we talked about some of the sensory changes and motor changes that affect speech and cognition. We really need to ramp up our voice to overcome those challenges. Typically, we need guidance or accountability through a speech language pathologist, and it requires some degree of repetitive drill. However, we keep things very individualized for each patient because we want it to be relatable to your real life and social context for communication. All right, that's it. Thank you.
Brandy, allow me to say that that was very, very, very well done. I very much appreciated your presentation as well as all the great work you're doing.
Thank you.
Thank you, Clarice and Brandy. What an outstanding presentation series. Let's go right to our Q&A. Okay. Clarice, I have a question for you. Do PD patients have a problem with urinary accidents?
They do. Not about 15% of folks, give or take, have that particular problem. It can be really frustrating, for sure. There are some medications, sometimes things like botox can be helpful. And also there is another great resource in our therapy department. There is a bladder specialist, if you will, and I believe in our physical therapy department, who can be really helpful as well. I also want to give just a little plug for our therapy department because I believe sometime in the next 6 months or so, they are also planning a sexual dysfunction talk in Parkinson's disease, which will touch on some of that stuff and then also some of the urinary stuff as well. So stay tuned for that. But yes, this is common. And we have some treatments as well. And again, another great time to have a good urologist.
Okay. Here's another question for you, Clarice. Is constipation without a sense of feeling bloated or full also linked to PD?
Yes, anything that discusses the slowed transit of the gut is part of that constipation and part of PD. A lot of my patients say, well, my constipation doesn't bother me. And that's fair. But again, I am really focused on making sure that your medications work as well as possible. So keeping your gut running regularly is really important to us as well. So still a good reason to do all of those things, increase your fiber, water, eat yogurt, things of that nature. Still really important, good for you, your overall health, but good for your medication absorption as well.
Okay. Okay, Brandy, I have a question for you. Are in-person speech therapy sessions done without masks? That's a unique one to what's going on right now.
No, they are done with masks. So I certainly would have a mask on, and then the patient would have a mask on too. If that feels challenging for you with the face mask covering your nose and mouth, we also have face shields. So there's kind of like an elastic that goes around your head and then a plastic shield over your face. So you feel like you can breathe a little bit better with that. I have some patients that prefer to use the face shield and some patients that feel okay using a face mask.
All right, thank you. All right, Clarice, I'm going to ask you one more question and then I'm going to hand this over to you to ask some questions.
Sure.
Is there an intensity or frequency of exercise, for example, daily 30 to 60 minutes of high intensity interval training on a stationary bike that provides therapeutic benefits similar and or supplemental to carbidopa-levodopa?
Absolutely. That's a great question. One of my favorite questions to answer. And as my patients know, one of the things that I tend to bother them with every visit is, are you exercising and what are you doing? The reason being, you know, the literature shows for us right now that the only thing that we truly know that slows down the progression of disease is exercise. And I know that Jared could probably speak to this a little better than I can, but the general gist is that exercise is incredibly important to a Parkinson's patient. It's what, you know, decreases your risk of falls, keeps you up and walking, keeps you moving. You've already heard today that it is great for your gut. You have also heard that it is great for your mood, any anxiety, any depression. It is perfect for that as well. So there's really no reason not to exercise. It is a little tricky because your apathy is going to play a role and you're going to tell yourself, oh, I'll exercise tomorrow, or oh, I'll exercise next week, or oh, I'll start. Just like the rest of us. So it is, you know, a little bit challenging to get started. So it's always great to start with a physical therapy program, and so they can really work with you and figure out what issues and what exercises you can do that help you specifically and the challenges that you have with your Parkinson's disease. But then at home, the best research talks a lot about riding an exercise bike in particular. It can be any kind of bike. It can be the cheapest bike. It can be the most expensive bike. Your improvement does not matter on the type of bike. A lot of my patients prefer a recumbent bike. So that for you're sitting down and pedaling in front of you instead of easier to get in and out of. But ideally, what I'd like you to do and what the research shows is that you want to exercise between 30 and 40 minutes a day. Most days of the week and slow. For some of the TV, go faster during the commercials and slower during your show if that's this routine. Good and account of some of those really great programs that are out there these days help in that. Just any exercise you can do on your exercise bike is likely to slow your progressive disease, and that's not something that we can say about any of our others right now we'll talk about that way. But right now, the best thing you can do for yourself is to ride that exercise bike as much as you can. Oh, and then let's see. A few of our other questions, Jessica, you talked about that. Oh, Brandy, I did have a question for you. For some of my patients always ask me this question. They say, well, how do I know, when do I know that I should see a speech therapist? Because they're often soft-spoken. And then after they've seen a speech therapist, their follow-up question is, well, should I go back, or how frequently should I go back?
Yeah, I think it can be good to see a speech therapist at any point in time when the patient feels ready to do so. So sometimes I have patients where I think really only unless you're a trained therapist would you notice any deficits, but starting exercises early, even the voice exercises, can be very beneficial to help maintain the great function that the person may already have. So I think as soon as the patient's ready, we can start an voice exercise program for them to continue on. And then we also kind of have a baseline so that, let's say 2 years down the line, the patient feels like they're having troubles with their speech or voice again, they can come back and we can kind of really see where they are and fine tune their exercise program. When we do our initial evaluation, we talk with the patient and set up a treatment plan about how many times per week we want to see the person and for how long. And at the end of therapy, we usually say to continue your voice exercises, and you can come back 6 months, a year, 2 years to kind of get a fine tuning on those exercises.
Fabulous. And a follow-up question. I know that we didn't talk about swallowing today. That wasn't part of what we were talking about. But my patients also ask, well, will my swallowing really get any better if I go do speech therapy with, for swallowing? Is that something that's actually going to get better? And then again, how often should I be doing something like this?
Yeah, there's a lot that we can do. We might recommend for the patient to have a more in-depth swallowing test called a modified barium swallow study, where we can really see what's going on when the person swallows and where we see deficits. And if warranted, we can give exercises to improve the swallowing. But even if we don't do that, there are a lot of tips that we can give the person to use while they're swallowing and eating. So it could be as much as slowing down, making sure you have a drink with you while you're eating and drinking. And then we have the person come back and say, hey, did any of those tips help you out? So we can fine tune what will help them more. So again, it's great to get a baseline, and it helps let us know if there's more problems coming up later down the line.
Great. And just to clarify, that means, so if I'm having swallowing problems, I can definitely get some improvement by doing some therapy.
Yes, you can, for sure.
Fabulous. Thank you so much, Brandy. I really appreciate you being here with us today. It is, I believe, getting time. Well, it's close for us time to take a break. Let's maybe answer one or two more questions. Let's see.
I do have one. I wanted to ask Brandy, do you recommend every patient with Parkinson's disease to do speech therapy, or only when there are important difficulties?
I think it can be great for all patients to at least come and get an evaluation and get some education to get going. There could be difficulties that maybe the patient isn't recognizing, so we could address those then. But even if I feel that things are looking pretty good now, I'm sure that there's some education that I can provide them for what to look for in the future and what they can do to promote communication going forward.
Maybe also joining the classes that you are giving online. I mean, exercise is always good. And I guess that also speech and voice exercises are good.
Yeah, the classes are absolutely amazing. It can help build a sense of community as well, because the other people there have Parkinson's. So it's a great way to maintain your function, even if you don't need intensive therapy at the time.
Thank you.
Fabulous. I think that it's time for us to take another break. So again, no worries if we didn't get to your question this morning. We will answer those questions at length, and we will post them on our website in the next couple of weeks so that you're able to read your answers. We will come back promptly at 11 and start presentation. So again, feel free to get up, as Jared told us, to stretch and get something to drink or go to the bathroom, and we'll be back in about 8 minutes. Thank you.
Hi there, I'm here whenever we want to start the session.
Hello, Dr. Changizi. Thank you for joining us. I think in a minute or two, Clarissa and Jessica will introduce you and we can start with this new session.
Hello, everyone. Welcome back. We hope that you're enjoying our event today, as well as learning some helpful information regarding managing your disease. Let's, of course, jump back in with another polling question. As before, select which statement you think is correct. The first option is, it is important to delay the start of carbidopa-levodopa for as long as possible by utilizing the other classes of Parkinson's disease medications. Option 2, the best Parkinson's disease medication to start depends on the individual. In some patients, carbidopa-levodopa may be the best choice, but research shows there's no long-term benefit to delaying the start of carbidopa-levodopa. I know we gave you a sneak peek by answering this question just a little early with Dr. Merola, but we'll see who is paying attention. Fabulous. It seems that most of the group listened very closely. And it is the second option, that it really just depends on the individual. And there's no reason to delay in general. So Dr. Changizi will talk to us a little bit about that. She is our next presenter. And Dr. Changizi, she holds her bachelor's degree in mathematics from the University of Virginia and neurobiology from the University of Maryland. She earned her medical degree from Duke University School of Medicine and completed her residency at the University of California, Los Angeles. She completed her fellowship at Albany Medical College, where she then went on to direct their deep brain stimulation program. In 2011, she became the co-director of the Center for Neuromodulation at Mount Sinai Medical Center. Dr. Changizi luckily joined the Ohio State University Wexner Medical Center in 2013 and specializes in treating patients with movement disorders. She is the director of the Movement Disorders Division Fellowship Program at OSU. And today she's going to talk to us a little bit about when and how to start pharmacological treatment for Parkinson's disease. Welcome, Dr. Changizi, and feel free to start whenever you're ready.
Thank you. Here I am. And I'm going to mute my video just so that I'm not distracted by it as I give this talk. But I want to say thank you for the warm welcome and to the over 200 people who are participating today. I hope some of you are my patients. I know many in clinic were planning on attending this. And so let me give an opener to why this talk is so important. Of course, we have surgeries to treat Parkinson's and we have sessions on that today. But really the mainstay of treatment for most of the duration of the disease is medication. And it's absolutely critical that the patients and their families or persons with Parkinson's disease understand why you're taking the medications you do, what are the active ingredients, what are expected side effects, and what are just coincidental. I get many calls, many emails, which of course is appropriate, but asking whether certain side effects are due to the medication, a reluctance to take meds. And these things, if you're really educated on why you're doing and what you're doing and what's to be expected and how to adjust the medications based on how your disease is doing at the time, you and your provider can do a much better job at managing your symptoms. So anyway, so here we go. All right, let's turn off this video of me. And I'm gonna try and change this. How do I change? Okay. Okay, got it. There's just a delay in changing my talk, so let's do this. I'll anticipate that. Okay, so the mainstay of treatments thus far in Parkinson's disease relies on the idea of dopamine deficiency. So what do I mean by that? In Parkinson's disease, there's been several lectures on this, but an area of the brain called the substantia nigra, which is in that slice of brain, what you see in that, that's an axial cut. You can see the slice through this person's head. And so this picture here is an area of the brain called the midbrain. And this black stripe is how this should normally appear on a gross specimen if you were to take a slice of brain out of your head. And what happens is that these cells in Parkinson's disease are slowly dying off, and these cells are critical because they make dopamine. And of course, the disease is much more complex than this. There's other brain chemicals that are important in other areas of the brain that are also affected. But this particular fact is leading to dopamine deficiency. Dopamine deficiency is the root cause of most of the movement problems that you see in Parkinson's disease, namely the rigidity, the slowness, and the stiffness. Here in this slide, this is the patient or the person with Parkinson's disease, and you can see the stripe is much more pale than the normal slice that's up here. And that's because those cells just aren't there in that black stripe and therefore unable to make dopamine. So in Parkinson's disease, the main focus is to increase the dopamine in the brain. Here is, this picture is showing two cells in the brain called neurons talking to each other. And in a normal brain, these little yellow spheres, this is the dopamine, and it's released by this neuron or brain cell onto this neuron or receiving brain cell. And here we don't have that happening. We have very little dopamine between these two cells, and they're having a difficult time talking to each other. And therefore, they're having a difficult time telling the body how to move appropriately. So replacing dopamine is the mainstay of treatment. So levodopa is converted to dopamine in the brain. And so dopamine agonists act like dopamine in the brain and mimic its effects. And certain drugs can block the metabolism of dopamine in the brain so it lasts longer. So these are the three main mechanisms that we use to treat Parkinson's. We either give you a drug that's converted to dopamine in the brain, we give you a drug that acts like dopamine in the brain, or we give you drugs that stop the metabolism of dopamine in the brain. There are two exceptions to this, which I will talk about later in the talk, but this is the majority of medications for which you're taking for Parkinson's. And here we see, this is the brain, the blood-brain barrier, which is your brain is sealed off from the rest of the body to protect it from inappropriate chemicals that could be mind altering. And here's this levodopa, which is crossing from the bloodstream into the brain to talk to a neuron or a brain cell. It's converted to dopamine. And now this brain cell can talk to the receiving brain cell over here. And can somebody let me know, maybe one of my colleagues can text me whether you can see my mouse on the screen. And so with the dopamine, these two cells can talk to each other, which they're getting from the bloodstream in the form of levodopa.
Kelly, just a confirmation, we can see the mouse, okay?
Thank you, Dr. Merola. Excellent. So levodopa is converted to dopamine in the brain. This is in the form of the drug carbidopa-levodopa, which I'll have in a future slide. Dopamine itself, you may say, well, if my brain is lacking dopamine, why don't I just take dopamine as a drug? But that cannot cross from your body, from your digestive tract and bloodstream into your brain. It is blocked by the brain. We have to give you dopamine in the form of levodopa, which can be carried in the bloodstream and then can cross out of the bloodstream through the blood-brain barrier or through the barrier mechanism the brain is set up to protect itself, and that crosses into the brain and it's converted to dopamine there. So your medication that we give you, which is the mainstay of treatment, is carbidopa/levodopa. A lot of you folks in my clinic call this your Carvi-Levo. And the second ingredient, the levodopa, is what is the critical component of that medication. And you'll see a number after that medication. You'll see 25-100, 10-100, 25-250. Those are the common forms in one of the formulations of levodopa. The first number is the amount of carbidopa in the pill, and the second number is the amount of levodopa in the pill. And that is the important number because that's the drug, as we just showed on the previous slide, that's converted to dopamine. We must get the levodopa into the brain in order to work, because the brain is what's affected in Parkinson's disease. That's what needs the dopamine, because those cells that make it are dying off. But outside the brain, in the stomach and the blood vessels, there's a chemical enzyme called dopa decarboxylase, and that's also trying to convert levodopa to dopamine. So your brain is trying to convert levodopa to dopamine, and the rest of your body outside your brain is trying to do it. But dopamine outside your body is not really helpful for Parkinson's disease. You need it inside the brain, which is where the disease is affecting you. And so this carbidopa ingredient in the front of it, in the first part of that drug, is stopping the dopamine from being, the levodopa from being converted to dopamine, and letting more of it get to your brain so that it can be useful. So the different ingredients here are the different ratios. And obviously when you look up at the top here with 100, 100, 250, the 250 strength has the highest amount of levodopa and is the most potent. And the first two drugs are just varying in the amount of carbidopa they have, but they have the same 100 milligrams of levodopa. So carbidopa levodopa comes in several forms. It comes in an immediate release pill, which is called Sinemet, and a controlled release pill called Sinemet, which is the trade name. And then we have a Parcopa, which is the exact same formulation of drug, except that it dissolves in the mouth. It's a dissolving formulation, but it doesn't really act any faster. You still have to absorb it through your bloodstream. So it's not like this is a more fast-acting rescue. It just makes it easier for folks who have a very difficult time swallowing the pills. Rytary is a long-acting oral capsule, which contains different beads. I'm going to have more on that a little bit later. We have Stalevo, which is a combination pill of carbidopa, levodopa, plus another medication called entacapone, which I will discuss in a bit. We have this Duopa intestinal infusion system, which is liquid levodopa, which is pumped into the small intestine through a pump that is surgically implanted. And we have Inbrija, which is an oral inhaler of levodopa. So Sinemet immediate release and controlled release is a very cheap generic drug. It's been around for decades. There's some pictures of it up top. That yellow pill is the most well-known IR. And it acts pretty quickly, typically within 20 minutes. And the duration of benefit really lasts on the severity of depends on the severity of your disease. So I've seen patients where, one pill 3 times daily covers them for 24 hours. But in later stages of the disease, when people develop motor fluctuations, the medications may only last, say, 2 hours before they start to wear off and folks feel slow and shaky again. The typical side effects of carbidopa levodopa are fatigue, lightheadedness, nausea, nightmares, and at higher doses, you can have hallucinations. Another side effect that I think is important to know is dyskinesia, which are the extra dancing-like involuntary movements. That is different than tremor in that they're much more swaying and dance-like, and these are from being over-medicated. And I'm making a point of this because I've actually had patients not realize that that is from the side effect of the medication, and that if we just turn down their medication or take a slightly lower dose more frequently, we can avoid that. That is not, that is something that is completely manageable. The CR in the sustained release formulation is a slow release. And in that, the pill is infused with this polymer that you have to erode through your digestive tract, and it slowly delivers the drug into the gut. But the problem is that in advanced disease or patients with really bad constipation, when you're trying to eat through that polymer to get to the levodopa, you can get very delayed or erratic kicking in. So CR, while its original intent was to help people with motor fluctuations, can quite often worsen them in patients, even though theoretically it's a sustained release. And that's why we often try to give you the controlled release mainly at night when you're sleeping and you're not so sensitive to delayed kicking in, and we stick to the immediate release during the day. The controlled release is also only 2/3 to 90% of the potency of the immediate release. So this is why we will sometimes adjust the dosing if we are converting you from one form to the other. Okay. If there's delays, it's because sometimes the page down is not working. There we go. Okay, so, and I'm going back up. Okay, so Rytary is another form of long-acting levodopa, and this is very different than the controlled release. This was FDA approved in 2015. This is a capsule that contains beads, which have two forms of levodopa. It has an immediate release levodopa, which is very fast acting, and a longer acting levodopa that is more slowly released and lasts longer. And these beads are mixed together in the capsule. You typically have to take several capsules at once. So a traditional dosing would be, for example, 3 capsules at a time, 4 or 5 times daily. And the advantage is that there's an immediate kicking in, but the long-acting levodopa leads to more regular, sustained levels of dopamine in the brain. So we would use this type of medication when patients are wearing off, when their medications are only lasting a short period of time, and they're getting very abrupt kicking off. So suddenly they'll be fine, and then within 15 minutes, the meds kick out, and then suddenly they can't move or can't walk or very slow. And this can be expensive because it's still very name brand. There's no generic available. But we have 2 programs. One is a patient assistance program, and the other is that we have a trial period coupon to give you free drug for the first 2 to 4 weeks of the medication. There's also a Duopa intestinal infusion system. We have that program here at Ohio State, and Dr. Mira is our general surgeon. Okay. So what this is that this requires a surgery to implant a tube that goes through the stomach and then through this tubing into the small intestine, which is the small intestine is part of the gut that's after the stomach that helps you absorb nutrients from the food that you eat, but also absorbs medications that we give you. So we attach this black square here is a cartridge with levodopa. Here's a picture of it. You can see this plastic pouchy thing that is providing levodopa through this tubing. And then this pump here, this little cassette helps you program. And so in this system, liquid levodopa is given into your digestive tract every few minutes, and you can bolus it if you are having some wearing off. And it's a very constant infusion of levodopa, which is an alternative, again, for patients who are having very short time periods of medication effect and maybe having to wake up every 2 to 3 hours overnight because otherwise they wear off their drugs. This is a system that is on 16 hours a day and allows you to have constant levodopa. Inbrija is levodopa inhalation powder. This is given in an oral inhaler, which is shown here below, this blue and white kind of cartridge. What happens is that it's kind of like a asthma inhaler, for those of you who are familiar with those. I mean, you take it through the mouth, and it's a rescue therapy for off periods being where your medications are failing and you're back to being off, and you need a rescue or a quick dose of medication to last you before you can take your next scheduled pills. You place a capsule into the inhaler, you place the inhaler into the mouth, and you inhale a powder form of the levodopa. The most common side effects of Inbrija are cough, upper respiratory tract infection. You can have some nausea. You can have a change in the color of your spit, which is very benign. And you take 1 to 2 capsules for any off period, no more than 5 per day. Dopamine agonists are a different class of medication. And the analogy I like to give with these, those of you who are my patients in clinic, I tend to use this thing of Coke versus Diet Coke, or, so if levodopa or dopamine is the Coca-Cola that your brain needs in order to function, we have things that mimic the effect of dopamine. And that would be like your diet soda, which tastes a lot like the real thing, which is, the tastiest and the best option, but they're a mimicker. And so that's how I can describe dopamine agonists. They act at the same areas of the brain that need dopamine to work, and they look a lot like it chemically, but they're not quite as strong, and they are mimickers of it. They are not converted to dopamine. So we tend to use these in early disease in persons younger than 70. And why? Because they're not quite as strong as levodopa, and sort of oddly, the side effects, particularly non-motor side effects, are actually worse for these medications than the levodopa. But it's a nice moderate drug to be given with a very nice sustained mechanism of action that's usually very well tolerated in younger patients, particularly 65 on down. Side effects from dopamine agonists include nausea, lightheadedness, hallucinations. Leg swelling is one that you will see in these drugs, but not with levodopa, and fatigue, with a very rare side effect of actual sleep attacks. The advantages, there was a question in the past, which Dr. Merola was alluding to, where they may not be associated with motor fluctuations. We no longer think that's the case, but the trials used to show that those patients on dopamine agonists did not necessarily develop them as soon. And but really now it's more that there's very long-acting form available. And examples of this would be pramipexole, shown up at the top. There's a patch called reticotine, which comes in different sizes, which you apply for 24 hours at a time. And then there's this ropinirole or Requip, which is given. And all of these, the pramipexole and ropinirole come in immediate release formulations as well as long acting. We do have a dopamine agonist, which is a little bit different than the three I just mentioned, which is called Apokyn and used for rescue. This is also a dopamine agonist, but what there's two ways that this is given now. The more traditional one that we've been doing for years is something that's a liquid that's given subcutaneously. That means it's given into kind of the deep layer of skin. You inject it really like insulin under the more superficial layers of skin, and it's absorbed that way. And this system is used as a rescue. It's extremely fast acting. And it's very potent, so potent that actually the side effects are more extreme than the other dopamine agonists I showed on the previous slide. This can definitely cause nausea, and it can cause pretty bad hypotension, meaning a drop in blood pressure. Now, we can work around that. What you have to do is come into the office and we give you a titration, so we know the dose that both works to curb your symptoms as a rescue, and also ones that don't affect your, don't drop your blood pressure or your EKG, your heart rhythm. But you do have to come in. It's you know, this is sort of a commitment. And if you take this medication, typically you have to take around the clock nausea medication in anticipation that you might use this injection as a rescue. So you chronically take a medication, for example, called Tygan, which is to prevent that nausea. There is now a new form called sublingual film of apomorphine, which is absorbed through the oral cavity. That's also used as a rescue. I will say, so that you don't have this problem where you have to learn how to inject with that medication. I will say that for some reason the slide is suddenly becoming a little fuzzy, not sure why. But it will kick in after 30 minutes. And this is, but you still actually have to take the chronic nausea medication even with this form. And there's a trial for continuous subcutaneous apomorphine infusion that's underway, and Dr. Merola is running that trial. MAO-IB inhibitors called selegiline, rasagiline, and safinamide. These are medications, and again, I'm going to put a shout out to someone that it looks like the slides are suddenly a little bit blurry. I can always convert to my own slides or share my own screen if this continues.
No, Kelly, we can see them fine.
Oh, so maybe it's my computer.
I don't have any problems. I think sometimes when you go from your computer, it looks blurry, but we can see that fine.
Oh, and now it's not though. For whatever reason, it suddenly stopped being blurry. Maybe it's the delay in the computer. So I'll say that for people listening. You know, I wonder if the blurriness is coming from the speed of your internet. So for folks who are seeing the same that I am, just hold on, and as the slide comes through the delayed internet transmission, you'll see it become sharp. Okay, so the MAO-IB inhibitors, these things that block the degradation of dopamine in the brain. So remember, I've just given you two classes of drugs which increase dopamine in the brain by giving something that's converted to dopamine or drugs that act like dopamine. This class of drugs stops the breakdown of dopamine in your brain. It is normal to break down dopamine in your brain. Your brain has sort of a housekeeping function. So it's making dopamine and it's breaking down the dopamine to keep nice pristine forms of this chemical about in your brain. But if we can stop that process of breaking it down in patients who are lacking dopamine in the first place, your brain sees more dopamine, which helps combat the disease. So one of these enzymes is called monoamine oxidase, and the type B is because we're trying to thwart that enzyme that is very specific to dopamine. Now, your pharmacist may tell you that you can't take these medications with cheese or wine, and we now know that that's not really the case. The warning for this class of medications for that is because they're related to very old school antidepressants where that was true. But these drugs, very specific for Parkinson's disease, have been very precisely chemically altered so that they really are very specific to dopamine, and they don't interact with other things like wine or aged cheese. Side effects, these drugs are extremely well tolerated, and they tend to be milder drugs. So we usually use them either very early in disease as monotherapy, like just alone, or we add them on to therapy to make the dopamine last longer that you're getting in pill form. The one difference from this is that selegiline is partly metabolized or broken down by the liver to an amphetamine derivative. I mean, amphetamine is the same thing as speed, okay, the street drug. But in this case, it's actually a good thing, because for patients with Parkinson's who are on sometimes many medications that are sedating, or the disease itself is making them tired, we can use this as a side effect that's useful by adding selegiline for morning dose medication. This can lead to potentiation of levodopa side effects, which I told you on the previous slides, and that would be things like nausea, lightheadedness, or those extra dancing movements from being slightly over-medicated. COMT inhibitors, this is another class of drugs. Here are the ones listed. Those are entacapone, opicapone, or tolcapone. Tolcapone we no longer use because there was a very rare but present risk of liver injury. But the first two, entacapone we've been using for years, and opicapone is a new one which has the advantage of being a once daily drug. Entacapone is a pill you have to take every single time you take levodopa or the Sinemet. So what do I mean by this? How does this work? Well, what happens is that there's a second enzyme in your body that also breaks down dopamine, and we are thwarting this one. So the previous slide was showing you one enzyme called monoamine oxidase, and this is a different enzyme in your body, or different chemical that breaks down dopamine. And so we're thwarting this particular enzyme to keep the dopamine in your brain lasting longer. Again, side effects are nausea, lightheadedness, fatigue, nightmares, hallucinations. Diarrhea definitely can happen, and these are particularly prone to be causing dyskinesia. Entacapone can make your urine orange. Don't worry about this. This is very benign and harmless. And Stalevo is a combination pill which contains carbidopa, levodopa, which same medications at the very beginning of this talk, and entacapone all in one pill. Amantadine is a medication that is what's called a dirty drug, meaning that it has many mechanisms of action. But don't be put off by that name. It's actually quite useful because it's helpful in a variety of ways to treat Parkinson's disease. We have the old school amantadine, which is an immediate release, which we typically take 2 to 3 times daily. I usually limit it to 2 in my patients. I think that you start to get side effects beyond that dose. And there's a new form of amantadine, which is an extended release, which is once daily. This is useful for tremor, dystonia, and it actually suppresses dyskinesia. So we will sometimes add that on in patients who are very prone to, at the peak of their dose, getting extra dancing movements from their levodopa to help curb that. It's cleared by the kidneys, so you have to use caution if you have kidney disease. You might want to speak up and remind your provider of that if you have some of that. Side effects are insomnia. You should always take the second dose early in the day. I have some patients who are told to take it twice daily, and if I neglected to tell them about the insomnia, they're actually taking it in the evening. You want to take it first thing in the morning and then early afternoon at the latest. It also is particularly prone to cause hallucinations. So I tend to avoid this in patients whose Parkinson's is starting to make them maybe have a little bit of cognitive problems or hallucinate. There's a lacy rash you can get typically on the lower extremities. That is benign. That is no reason to stop the drug. You can have edema or swelling in your legs. Again, not dangerous unless it's significant. And there's an extremely rare chance of something called corneal edema, which would be immediately picked up by your annual eye exam. So I would recommend that you do that. The mechanism is that it increases dopamine release. It keeps dopamine around between the cells that are talking to each other, and it's something called an NMDA receptor blocker. I only have, there's only, I believe, 2 more drugs, just for those of you who are worried about the time here. One class of drug, another class of drug is something called anticholinergic medications. And examples of these would be trihexyphenidyl and benztropine. The trade names of this are Artane and Cogentin. We don't often use these drugs, but I do inherit some patients who've been given these. So it's, and I would definitely be aware that these medications are used predominantly for tremor. They do not have effect on slowness or stiffness in Parkinson's, but they are used particularly on younger patients who have tremor predominant disease. And the reason we tend to not use them in older patients who are more prone to side effects or patients who've had the disease quite a while is that by blocking acetylcholine, that's how they work, the chemical acetylcholine in your brain is used for thinking. And so you can actually have your memory and cognition be poorly affected by taking these medications. So we tend to take these drugs off and stop them in later stages of the disease to keep your thinking intact. They can also aggravate constipation and urinary retention, which can be particularly problematic in patients with advanced Parkinson's disease or older men who have some prostate issues. Norians, or istradefylline, is an oral medication with a completely new mechanism. And so this is a bit exciting. Those of you who are asking me about medications, what's new on the market, this is working through something called alpha-2A receptor. It's an antagonist for blocking this receptor. Don't worry about this specific detail, but the main idea is that it has nothing to do with dopamine. Whoop. There we go. It has nothing to do with dopamine. It's a medication that is completely working by a novel mechanism. And I like this because it's providing hope for the future that we will be broadening our tactics to combat this disease. It is used typically as an adjunctive, meaning we add it on to levodopa for wearing off symptoms. It's been around since 2019. And the most common side effect is dyskinesia, about 12 to 13% of patients compared to 4% with the placebo or fake drug in the trials. Other side effects, it could cause lightheadedness, constipation, nausea, hallucinations, insomnia, and very rarely something called impulse control disorders, which are disorders of risky behaviors of short-term gain with long-term negative consequences. Examples of that would be gambling, drinking, smoking, shopping, hypersexual behaviors. And I will add that, all of these things are okay to do with the exception of smoking in moderation. But when these things become very dominant in the lifestyle and problematic to relationships or to finances, then that is known as an impulse control disorder. Waiting for the slide to change, just a second.
Yeah, there is a little bit of delay.
I think that's the end of my talk, honestly, Ari. so I will wait for the slide to change, but there we go.
This is an excellent presentation. Thank you, Dr. Chinghisi. I will go with a couple of questions for Dr. Chinghisi so that we can move next. This was the most important presentation of the morning, probably. I'm sure there are some questions. Any questions, or should I be looking at the chat box? Is that what I should be doing?
I will go ahead and feed you some questions, Dr. Chinghisi.
All right, I am alert and waiting.
So can you talk to folks a little bit and speak to a little bit about what over medication might look like and what that might mean in a Parkinson's patient?
That is great. And I'm going to leave my camera on because I'm actually going to mimic this. There we go. Yes, I'm doing that. So, okay. So Parkinsonism, as you heard earlier, are cardinal features of stiffness, slowness, tremor, and balance. The slowness and the tremor are really often the most noticeable, but there we go. So that's how you look when you're off your medication. Being over-medicated would be when you start to swing up and you feel those symptoms subside, but then at the peak of the dose, you start to move excessively. So it's not that you can just move more easily. Now you've passed that threshold of moving more easily and you're actually moving excessively and involuntarily. And it often looks like, here we are in my study. And so it's usually these kind of dancing swaying movements where people do, their mouth can move like this. You might have tongue movements. And that's very different than a rhythmic shaking. This is tremor. This is dyskinesia. And a really great way to figure that, how that looks, is to look at any videotape of very famous Michael J. Fox, who has Parkinson's disease, as we all know. When you see him talk, he is usually typically and deliberately over-medicated because he would rather move easily and have excess movements than be the other way around, too slow. So when you see him and he's kind of on stage dancing like this, giving your lecture about Parkinson's, he is on a high dose of medication that's making him move excessively. And that is shielding or hiding the Parkinsonism symptoms. Does that help?
It does. It's perfect. I have another question for you. If once a patient starts levodopa, what is the normal time it takes to see any improvement?
So typically the medication should kick in within 20 minutes. And then as it continues to go through the bloodstream, be taken up by the brain and be converted to dopamine, you will have lasting benefit. So you may hit the peak of the dose, say in about an hour, hour and a half, or even, and that benefit may be sustained. It is very dependent on the state of disease. So if you have early disease, you will feel great for many, many hours, and that's called the honeymoon stage. If you're in later stages of the disease, two things may happen. The medication will only last a short period of time, anywhere, say it like 5 hours, 4 hours, then it will drop off to 1.5 hours. But you may also have dose failures, which means that you'll take the pills and then you're kind of waiting, and then they fail to kick in. And that's because the disease has progressed so much that that it's very erratic utilization of the dopamine by the brain. And that's usually when we talk about more advanced therapies, such as the pump, surgeries, which I'm not going to steal the thunder of my colleagues who talk about that, or the long-acting levodopas.
Great. And to step back to some of our folks who are first starting levodopa, I just want to clarify. So sometimes it can take a couple of weeks for us to see, especially if you're at a lower dose than when we first start levodopa. I think you'd agree with that, Dr. Changezi. So that, when you're first starting, sometimes we don't have the dose perfected yet. So if you don't notice anything, that just means give us a call and we can, see if we need to adjust the dose until we get an effect.
Yes, I concur.
Is there any medication in particular that might help with gait freezing?
Okay. And then Ari can talk a little bit about this too. So this is the holy grail of Parkinson's. And there's been some studies that, okay. So I would say there's three things. One is if you start having gait freezing, the first thing we do is try to ascertain or determine whether you are freezing. Let me explain gait freezing. Gait freezing, which may have been mentioned earlier, is where your feet just won't work. It's different than shuffling. It's where your feet are frozen in place and you just can't move forward. So you're not just slow, which is a problem that's very common. It's that your feet are really just stuck like a magnet to the ground. So the first thing we do is try to figure out if your gait freezing is dopamine responsive. So we'll, for example, increase your dopaminergic medication and see if it responds. But sometimes that doesn't do it, and the gait freezing is not dopamine responsive. In that case, we may try something called the amantadine that I mentioned. That's been shown sometimes to have benefit. There are some reports of the MAOIB inhibitors. So that would be, in case you're not remembering that name, like the rasagiline, the sulfonamide. We will try those medications to treat the gait freezing, but it can really be a problem. Ari, do you have thoughts on that? Is there anything I'm missing there? Dr. Merola, excuse me.
No, I think that was very accurate, and thank you for describing. The freezing of gait is a very difficult symptom to treat. Sometimes it responds to physical therapy, sometimes to medication. Sometimes it doesn't really respond to neither of them. It is one of the typical situations in which it's really important to examine the case, and each case may be different from the other.
Agreed. We do need to move forward, so we're going to go ahead and move on. We're going to move on to our panel, which is going to have a very interesting discussion. Thank you, Dr. Changezi, for the great presentation. We appreciate it. Always so many questions about medications. Remember, we will continue to answer those questions, and you will have answers posted at a later time to the website. You're welcome. So right now, I think that I'd like to just go ahead and skip forward to get right into our panel discussion. So we are going to have a wonderful panel discussion instead of a more formal presentation with some of our wonderful providers. So first we will have Dr. Merola, who you are all familiar with. He's the director of our Madden Center and is fantastic. We also will have Dr. Dong. He is one of our neurosurgeons. He did his neurosurgical residency and fellowship training at the University of Iowa. He moved to Houston, Texas, and he worked at Houston Methodist and served as the director of pain and functional division prior to joining us here at OSU in 2019. We also have Dr. Krishna. He is a neurosurgeon scientist with expertise in neuromodulation and functional neurosurgery. In his lab, he investigates imaging-based therapies, specifically focused ultrasound and image-guided deep brain stimulation, and provides imaging guidance to improve patient outcomes after neuromodulation procedures. He has co-developed a tractography-based technique for improving the safety of focused ultrasound ablation in patients with essential tremor. And he's also currently investigating the application of focused ultrasound for resistant epilepsy and advanced Parkinson's disease. New to our series this particular time are our two nurse practitioners, Jennifer Godowski and Rosina. Jennifer has been at OSU since 1994. Started out in veterinary medicine, but decided that she liked people a bit better, so she decided to become a nurse in 2014. She worked in critical care for quite some time, and then eventually became a acute care nurse practitioner. We have been lucky to have her with us in the center since 2016. And then Rosina graduated from OSU in 2017 with her master's degree in nursing. She is a family nurse practitioner. Previously, she worked as a rehabilitation nurse at OSU's inpatient rehab, serving patients with a variety of medical conditions and needs. So I am going to turn it over to you, Dr. Merola, for this panel discussion.
Thank you. Thank you, Clarice, and thank you to all of my colleagues, the panelists, for joining me. So I try to go ahead and share my slides. I hope you can see them. Do you mind giving me a feedback if you can see them?
Everything looks great.
Very good. So speaking of advanced therapies for Parkinson's disease, we surely have to go into deep brain stimulation. So deep brain stimulation is probably the most exciting innovation that happened in the field of neurology over the last 20 years. And it is still so exciting that seems like something new, but even though this has been around for quite a long time at this point, so it's a very well-established therapy. And I would like to ask our two neurosurgeons very briefly, maybe Dr. Krishna can start, to describe what is the key concept of deep brain stimulation. And then later I will ask Dr. Dawn to discuss a little bit about what are the different targets. Dr. Krishna?
Thank you, Dr. Merola, and thank you for all the providers for being here for this educational opportunity. So the question that is posed is, what is deep brain stimulation and what's the rationale for deep brain stimulation? And so the way I understand deep brain stimulation is that it reestablishes the balance between circuits in the brain that are slightly out of sync in Parkinson's disease. In patients with Parkinson's disease, when dopamine is less in the system, there is slight desyncing between areas of the brain that support movement and areas of the brain that stop movement. So a good way of thinking about this is if you were to think about a car, and how in a car you have gas and you have brakes. For a properly functioning car, you have to have a car that has gas and brakes that are in sync. If you were to have a situation where the brakes are slightly less effective, or the gas is slightly more, the car would have extra movements or less movements at times where you wouldn't want those to happen. In Parkinson's disease, when we have less dopamine in the system, there are times where the gas is slightly more, other times there are brakes that are slightly more. So patients can have tremors, which are extra movements, dyskinesias, which are extra movements, and other times you have more brakes, thereby patients have bradykinesia or stiffness movements. The goal of DBS in a situation like this is to reestablish this balance between gas and brakes.
Excellent. Thank you, Dr. Krishna. And Dr. Dawn, can you tell us a little bit about what do we mean with targets? So we place these little electrodes but why sometimes we place it in certain brains areas, sometimes in other brain areas, and is one target more difficult than the other?
Yeah, thank you, Dr. Merola. So we kind of had a lot of discussion from Dr. Chingizi about the role of dopamine and how all this kind of stems from a breakdown of the production of dopamine from the substantia nigra. Ultimately, what these neurons do, even though they're from the substantia nigra, they project to a bunch of different areas in the brain. We kind of collectively call these different structures the basal ganglia, and they all kind of communicate with each other. So they have neurons that project and go back and forth. Two of them that are really important when it comes to deep brain stimulation are the subthalamic nucleus. So you'll hear us say STN quite often, and the globus pallidus internus, or interna, or GPI. So the globus pallidus is actually composed of two kind of distinctions. We say GPI or GPE, E for the external segment, I for the internal segment. And then the STN, or the subthalamic nucleus, is the other major target. And they all kind of communicate with each other, but these two structures are the ones that we primarily target when it comes to deep brain stimulation therapy for Parkinson's disease. And they've both been shown to have positive benefits and positive outcomes, particularly when it comes to the motor effects from Parkinson's disease. So decreasing the tremor, improving the bradykinesia, or the slowness of movements. Reasons why we might choose one over the other. The STN location is very commonly used, and one of the main reasons for it is that oftentimes when patients come to us for implantation for deep brain stimulator leads, we're talking about surgical options for Parkinson's disease because the medications aren't giving us the benefits that we're looking for. We're having side effects from the medications, having unwanted what we call motor fluctuations, which are kind of these swings in the dyskinesias, in the off states, or states where the medications don't seem to be working very well. And the STN location specifically really allows us to be able to effectively control some of the symptoms of Parkinson's disease, but also lower the dose of some of the medications that we can use to a greater extent than the GPI, for instance. GPI is a good target as well. It does works very effective for controlling the symptoms of Parkinson's disease. It's very good for people who have significant problems with dyskinesias. So one of its main indications is very prominent dyskinesias with Parkinson's disease, and GPI can be a good target for that. Also, there's some of the side effects or complications that can go along with surgery. We do worry about, we've had some questions about this earlier, with memory issues and cognitive impairment. And this can be affected more with STN location lead placement versus GPI lead placement. So as part of the workup and consideration for potential surgical candidacy for treatment of your Parkinson's disease, now we have everybody undergo a neuropsychological evaluation, where one of the big things that we're looking for is any underlying problems with what we call mild cognitive impairment. Is there any evidence of any dementia that's present? And some of these findings may swing us one way or more so than the other for STN versus GPI lead placement.
Excellent. Thank you, Dr. Don. So just to summarize, we can say that we tend to go with one target called STN because it allows us to reduce the dosage of medications. However, when we believe that this might be potentially, increases the risk of cognitive impairment, we tend to favor the other target called the GPI because it has fewer cognitive effects. Now, let's move to the second point, which is in the end, this therapy is an advanced therapy. How much improvement does it bring, not only on the tremor, but on the quality of life? So in 2013, this important study was done, and basically patients were randomized to receive either the best medical therapy or deep brain stimulation. And what was noted was that patients randomized to receive deep brain stimulation had a significant improvement in quality of life. So they perceived a significant benefit, not on measure that we can assess, but on measure that they could assess by themselves. So this prompted the adoption of deep brain stimulation earlier and earlier, because before we used to do this therapy only in very advanced patients, and now we consider for deep brain stimulation patients with as early as 4 years of Parkinson's disease. The question that I have for Jen Gadansky and Rosina Davis is, in your experience, what is the improvement in quality of life that you have noticed with your patients?
Yeah, I mean, thank you. I'm reminded actually of a patient of all of ours that played pickleball and was having more and more difficulty with his movements. And once we did implant DBS, he went back and was, I think doing great, was in competitions and stuff within pickleball. So I think very clearly that was something that was very important to him. He enjoyed it a lot. He was not doing as well without the therapy. And I think implementing it really did improve his quality of life for sure.
Thank you, Jen. And Rosina, do you want to add your experience?
Sure. Basically mirroring that a lot. We know that if people start to lose function, that it's really harder to get it back. And so with early stimulation, people can move better, they can do things better, and therefore they can do things like their physical exercise, their exercises, physical activity, things that we know benefit patients with Parkinson's. And a lot of them can reduce the medicines that they have to take, which is really good, especially if they've not necessarily tolerated them well or had some side effects. And that really makes a lot of people happy to reduce their medicines.
Excellent. So if the study said that the deep brain stimulation brings to a 30% improvement in quality of life, would you agree in the real life experience that this is accurate?
Yeah, I would say this is accurate. And seeing some of these patients are, what I'm seeing is that patients are able to describe activities that they're doing today that they stopped doing, say, 4 or 5 years ago. So once you had deep brain stimulation, you started to do things that you couldn't do 4 years or 5 years ago. So in my mind, if I were to think about it, it almost shifts the clock back by 4 or 5 years, where you're starting to do activities that you couldn't do at that time. But we know that Parkinson's is progressive, and as the disease progresses over time, we are able to actually change stimulation to even catch up to that. So
that's a great way to put it. Thank you, Dr. Krishna. The next slide, I want to discuss some of the innovation. So there are surgical techniques called the stereotactic frame, as you can see on the left side of this slide, which is very well established. And this is a very high accuracy tool that allows performing surgery with greater accuracy. But I also put on the right side of this slide a robot. And this is because robotic surgery is emerging. And since Dr. Dawn is mastered the technique of robotic surgery, I would ask him to describe in 1 or 2 sentences what's your experience with robotic surgery and what do you think is going to provide an extra layer of improvement?
Yeah, thank you. I think with these procedures, we're always looking to try to improve accuracy of placement or have better confidence that what we're doing in the OR matches. So we have different ways of doing that. We have microelectrode recording, we have intraoperative imaging, we have awake testing, but we also have to verify that the mechanism for how we're placing our leads and our cannulas are accurate. And the gold standard for DBS lead placement for what we call stereotactic neurosurgery is frame-based, arc-based placements, like you see on this picture here on the left. There are some errors that can be done with that can come into those types of applications. The frames can warp. Sometimes the arcs and the rings themselves can have some over years of use, they can have some issues where we can see some inaccuracies in lead placement. So the robots kind of circumvent that. So they can be calibrated at any time, and they are just routinely the companies that this one in particular, Renishaw, they come by routinely and calibrate the machine to make sure that it's staying accurate on a routine basis. We also have ways of verifying intraoperatively the accuracy of the robotic arm. So we get merges. This is an example here. So we have the ability to get CT scans. We can either do this in the OR, we can do this out of the OR. This in particular instance is what we call the O-arm, which is an intraoperative CT scan. And so then we can merge the CT scan with the frame in place to the preoperative imaging. And then we can verify that merge through two ways. We verify it through the software. So we have to verify the merge when we put them together. But then we also use the robot to verify the merge as well. So we put what we call fiducials or markers on your skin, sometimes even on the skull. And then we use that robot and pick that point, pick that fiducial, pick that marker, and we try to verify that that spot is accurate. And if it's off, then we can correct for that prior to doing the surgery, prior to putting the lead down or the cannula down. So overall, it's a way to try to improve accuracy and improve precision of the surgery.
That's excellent. So just to summarize, we can use the robot in the operating room to increase accuracy, and we can do into the operating room a CT head to further increase the accuracy and confirm that the lead is perfectly placed. This is a great innovation that further improves the accuracy of the procedure. But I want to ask Dr. Krishna to comment a little bit about a technique that he masters, which is tractography. So tractography is an additional tool that is offered only in very few specialized centers to further improve the surgical accuracy. Dr. Krishna, can you tell us something about that?
So the innovations in the past have given us insights into understanding that the effectiveness of DBS comes from stimulating not only the area that we have implanted the electrode that Dr. Dom and Dr. Merola mentions as targets, but also brain connections that are connected to these areas, surround these areas as well. So brain is a highly interconnected and a integrative system. And over the last decade, it has become clear that certain connections in the brain are highly effective for improving patient symptoms of Parkinson's disease, while other brain connections can give side effects. So it becomes really important to map out these connections that we should preferentially target or preferentially avoid before we do surgery. And the technique to do that is called tractography, where we do a high resolution MRI. And this MRI allows us to tease apart brain connections that we should be implanting the electrode next to and brain connections that we should avoid. So in the picture on the left-hand side, you can see we are showing a part of the brain called VIM in golden. And the red fiber tracks and the blue fiber tracks are the tracks that we should avoid because these could give side effects. The picture on the right-hand side shows you the green fiber tracks that we aim to target during surgery, and these are the fibers that give improvement in patient symptoms. So using this technique at Ohio State, we are able to map out patients' brain, personalize treatment plans, really understand patients' brain anatomy from the inside, and improve the safety and effectiveness of DBS surgery.
That's excellent. So in other words, the brain is like electrical connections, and we want to make sure of target exactly the electrical connection that is associated with improvement of symptoms and not the one that can cause side effects. And this is not a standard procedure. This is an advanced procedure that we do thanks to the expertise of our team, but not many centers actually do it. And a couple of words also about surgery without surgery. So what is called the focus ultrasound. We only have 30 seconds, but Dr. Krishna, can you please explain in 30 seconds what this is?
So focused ultrasound uses the energy of ultrasound beams, thousands of these beams focused into one little spot in the brain. That causes ablation in the brain to restore the balance between gas and brakes. And this treatment is approved for the treatment of tremors in Parkinson's disease and is being investigated to test its effectiveness in improving dyskinesias or fluctuation symptoms in Parkinson's patients.
The question I have for you, Dr. Krishna, is this the first choice or we still consider this only when DBS is not indicated?
So in my mind, deep brain stimulation is still the first choice in patients with Parkinson's disease. And the reason being that this procedure is approved only for one side treatment at this time. And most of our patients show up with disease on both sides of the body. And so deep brain stimulation is the first choice for treatment. The other aspect, Dr. Merola, is that as you know, that deep brain stimulation is able to address all the symptoms of Parkinson's disease: slowness, stiffness, tremors, sometimes dystonia, while at this current stage, focused ultrasound is able to address predominantly tremors and dyskinesias in one side of the body.
Excellent. I want to conclude with only one last question to Jennifer Gadansky. And this question is, current technologies for deep brain stimulation offer us normal batteries and rechargeable batteries. What's your experience with normal batteries versus rechargeable? Pros and cons?
So I would say for sure the pro of a non-rechargeable battery is the fact that there's no maintenance with it aside from having to go back to surgery when that battery gets depleted. So that can be 5 years, give or take in the direction of more or less with a non-rechargeable battery. So it's kind of implant and move forward with life and not have to think about recharging or anything like that. The con obviously is more frequent surgeries as opposed to a rechargeable battery. They are lasting up to 15 years. That's a pro for sure, not to have to go through surgery multiple times. But the downside is clearly there is some maintenance associated with it, and that is recharging it. I think also the downside potentially could be is if, depending upon how well you are with technology, I think they're doing a really good job. All of the companies right now are doing a really good job of making it as intuitive as possible for patients to recharge their batteries. However, if cognition, if something, that comes along with it as far as just not feeling comfortable with recharging, that can obviously be, a significant issue or a con with regards to that. But for sure, not having to go through surgery, 3 times versus, once, I think that it presents a big problem for patients with Parkinson's and anesthesia that can sort of tend to knock the wind out of any of our sails, let alone someone with Parkinson's. It really sort of takes a while to get back to the baseline or what they feel is their baseline.
Thank you very much, Jen. So we are a little bit over time, and I do apologize for that, but I think it was such a great discussion. Thank you again. And I give back the word to Clarice and Jessica, who are directing us so well. We have a little bit of delay. Clarice or Jessica?
Dr. Merola, I can't start sharing my video. I'm stuck by the host. So we are out of time. Dr. Merola, if you would like to make concluding remarks, or if you want to spend a few brief moments discussing the research that we're doing, but we are most definitely over time.
Oh, I can go ahead and share just a couple of updates on research. I do apologize for keeping people on the call longer than needed, but I will try to be quick and just share a couple of updates about research. So I started, please give me a feedback that you can see the slides.
We can.
Okay, The most important part I want to say about research is that we have an email address. If you're interested in research, please contact us at this email address. This is going to be posted on the website, so don't run writing this down. We're going to put in the chat box in the website. So you are more than welcome to contact us, and we can see whether there is a good fit for you. We have many trials going on. There is also the possibility, and this is something that we're going to implement in our website real soon, to navigate the different trials available at The Ohio State University through what is called the study search. You just go on this link and type Parkinson, and all of the available trials will appear to you. Something I want to say is that Parkinson is a disease that is very multifaceted. So there are different stages of disease. There are different problems associated with the disease. And so there are also different research opportunities for different stages. There are patients that may be interested in a research opportunity for the very early stage, and patients that might be interested for a research opportunity of the more advanced stage, or maybe for one of the symptoms. So it's important to discuss exactly what is the goal that you want to get from a research trial. But regardless of that, I want to present a couple of the most important efforts that we are leading. This is called the PD generation. It is not available yet, but it will be available in a couple of months. And basically, we will be able to offer patients the possibility of getting genetic testing for free. Genetic testing in order to see whether they are carrier or not of any genetic abnormalities associated with Parkinson's disease. This is going to be done completely for free, and whoever is interested can start contacting us. Keep in mind, we're in a very early stage, so we will be able to actually do this in approximately 1-2 months from now. But we can put you on the waiting list. Something that we are starting as well is a clinical registry. What does it mean? It means that we are going to try to really make a difference in the treatment of Parkinson by creating a registry that not only captures the very basic information about Parkinson, but really can go into deeper level of understanding of the symptoms of each single individual. Because we know that Parkinson is just a big umbrella term that really encompasses such a big number of different conditions. So what we are offering, and is going to be totally for free, is if you are willing to participate in this registry, we will just ask you to complete a couple of additional clinical scales. We're going to evaluate not only your Parkinson's disease severity, but also your quality of sleep, whether or not you have autonomic symptoms, whether you have non-motor symptoms. We're going to evaluate and keep track of your quality of life, and also do some neuropsychological testing. This information is going to be available to you, but it's also going to participate into a registry that's going to help moving forward the research to better understand the complexity of the disease. And we're also going to offer you the possibility of evaluating the blood pressure changes. We're going to do a computerized gait analysis and tremor analysis, and motion analysis. We're even going to use a technology called near-infrared spectroscopy. So we can really get a lot of information that's really going to be very, very helpful. And all of this information together, combined with the DNA analysis, are really going to tell exactly what subtype of Parkinson you have, but also are going to help us as researchers to understand better this disease and figuring out better what are the therapeutic options. Not just one size fits all, but individualized precision medicine approach. We do have studies for early stage Parkinson's disease. For those patients that don't want to take carbidopa-levodopa, we have a study very interesting with tavapadone, which is a new medication. So if you're interested in exploring new medications, this is something that we can discuss. For the sake of brevity, I'm just going to mention this real quick, but if you're interested, contact us and we can discuss more. And something I want to bring to your attention, we have an effort for robotic assisted physical therapy. We are actually recruiting the few last patients in order to complete this study. And the goal for this study is to understand whether this device that is a little robot assisting walking can significantly improve the postural stability, the walk, and the gait in patients with Parkinson. Raquel is leading this effort. I even put the email address here. She offered to put even her working telephone address. But again, if you're interested, just contact us and we will put you in contact. Now, I just want to spend the last few minutes to talk about something that is very, very cutting edge technology that we're doing at the Ohio State University. And I want to let you know that this is Ohio State University is leading the field of gene therapy in the entire country. Gene therapy is one of our main areas of investment intellectually and in terms of clinical trials. And is a very complex approach. Is an approach in which we are thinking about not only understanding the DNA complexity from our patient, but actually replacing some of the proteins that are not produced anymore in the brain of patients with Parkinson using gene therapy. I'm going to explain real quick how this works. Let's say that we have a gene that doesn't really work well. Now we have the technology to replace this gene with another copy of the gene that works better. And the gene we are replacing in Parkinson, what you find here is just an example of a successful example of gene therapy. But what we're doing in Parkinson is actually providing neurotrophic factors. So a protein that can help supporting the survival of neurons. It is very complex. So we take this new gene, we put it into a little teeny tiny virus that we use as a vector to deliver this gene inside the brain in the cells that needs to be treated. And this little virus acts as a vector, goes to the cells and deliver this DNA, which starts producing this extra protein. The way we are doing this is still with brain surgery. So what you see in this image, these white spots are the areas of the brain that we injected with this gene therapy. And the results we are seeing, they're still very preliminary, but they are very promising. So I can show you the results from a publication that was recently done. You can see on the left, on the upper panel, the amount of dopamine produced in a patient before gene therapy. And you can see that there is some yellow that indicates a certain level of dopamine production. But if we go on the lower part of the panel, what is called the panel C, both on the left and the right, we see the same patient 6 months later. And we see that what was yellow actually turned out to be red, which indicates a higher concentration of dopamine production. So we are very excited about these preliminary results. I have to say that at this time, we have already treated a few patients with gene therapy. We are waiting to confirm these results. And if this is positive, probably in a year or so, we will start opening the third phase of the study. And whoever is interested is more than welcome to participate. I will stop here because I don't want to take too much of your time. But I also want to say thank you very much for being here with us today. This is a moment of connection that I believe it's very, very important, both to explain what we're doing, but also to get feedback from you and understand what we can do better. So thank you very much. I give back the word to Clarice and Jessica, who are the leaders of this event today.
Fabulous. Thank you so much, Dr. Merola, and thank you to all of our panelists. Wonderful discussion. Apologies for running over time. That's obviously all the time we have for today. Again, as Dr. Merola said, if you have any more questions about research, please feel free to email us at rpdresearch@osu.edu, osumc.edu. I will make sure that I have it correct in the things that we send out to you and the things that you can find on our website. Our website is in the process of being updated, if not fully updated. So you can also log on to the wexnermedical.osu.edu/movement to learn about some updates in our program. Our next program, likely still to be virtual pending COVID, will be held on July 17th. And it will have a pretty big focus on some balance and gait things, as well as some other good things that we have in store for you. You will, of course, get you will be notified via email, potentially via mail. We will definitely let you know about the next session. We're so glad that you were able to join us today. Again, we apologize for running over. We will answer all those questions and also get those answers put up on the website as well. So thank you so much for joining us. We look forward to seeing you in the future. And as always, send us any questions that you may have.
Can I ask all panelists to turn on the video just for a brief salutation? And so a special thank you also to all our panelists and looking forward to the next event. And thank you so much to Clarice and Jessica for leading this.
Thank you, Ari. I'm sorry we were not able to start the video, but thank you all.
Technical issues. Goodbye.